Testing. There we go. Well, the committee will come to order. Welcome to the Ways and Means Committee hearing on the tax treatment of health care. It's only fitting that this important discussion falls during tax week, time when Americans are reminded how unfair and overly complex tax policies are hurting workers, job creators, and families. We can all agree Americans deserve better, which is why we're working towards solutions to make our tax code simpler, fair, and flatter for everyone. Today, we'll examine proposals to reform the tax code to help all Americans access more affordable health care, including proposals to create a new fair tax credit and encourage greater use of consumer-driven health care models to spur innovation and lower costs. The tax code is full of provisions affecting the quality and the cost and the accessibility of health care for millions of Americans. Currently, the tax code contains over a dozen health-related tax expenditures, all intended to help more Americans access health care by subsidizing many of the costs. Unfortunately, using the tax code in this way also can have the opposite effect, increasing premiums and costing taxpayers trillions of dollars in the process. Let's consider the largest health tax expenditure for employer-sponsored health insurance plans, commonly referred to as the employer exclusion. Congress incorporated this highly popular tax break in the tax code decades ago so that employers could attract and keep workers during a time of wage freezes. At the time this provision was created, the labor market and the health insurance market both looked very different. Today, more than 150 million Americans under the age of 65 get their health insurance through their employer. Our conversation today is about how we can preserve and modernize this important tax incentive at work while also expanding tax benefits to Americans who seek additional health care choices. And perhaps the crux of this hearing specifically is how can we make this nearly 100-year-old tax break more flexible so Americans can have a new, modern option to choose a health plan that fits their needs and can travel with them to a new job, to start their own business, or to raise their family at home. Some consumers today feel confined by their employer-sponsored arrangement because they're required to choose a plan from options determined by their employer, rather than getting to shop around for the plan that best meets their needs. Others who select health insurance through their employer feel trapped in their current job because they don't want to lose the coverage they like. The tax code compounds those concerns because this pre-tax benefit is tied to the job, not to the person. This approach limits options, is unfair to those who don't get their health insurance through their job, and creates what many economists call job lock. Additionally, the employer exclusion is a contributing factor to our country's stagnant wage growth. That's because the tax code incentivizes putting a greater share of compensation toward non-taxable health plans and less to taxable paychecks. So as health care costs rise, employers divert increases in salaries to health care at the expense of take-home pay. Evidence also suggests that the employer exclusion leads to higher health care costs for all Americans. Oftentimes, someone who participates in an employer-sponsored health plan doesn't face the actual and increasingly expensive cost of care. This encourages beneficiaries to consume more health services, including services they may not even need, driving up overall costs. I cannot emphasize enough the employer-sponsored health insurance market is a vital one. The question we must wrestle with is how we can sustain this option while advancing reforms that make the tax code fair and health care more affordable and flexible for all Americans. We need bold solutions to tackle this challenge. Not, in my view, Obamacare's punitive tax on a high-cost health insurance plan that the law itself has made even more expensive. We also need to consider expanding consumer-driven health care. It's a model that empowers consumers, not the government, consumers to unleash the forces of choice and competition to lower costs and increase quality. Yet for many people, Obamacare has limited the consumer-driven plans they liked, including health savings accounts and flexible spending accounts. This committee will continue to protect and expand opportunities for Americans who want to take control of their health care dollars. I want to thank our expert panel of witnesses for being here today. I look forward to a robust discussion about how we can help all Americans, regardless of employment status, access the affordable, portable, quality health care choices they deserve. With that, I'll yield to the distinguished ranking member of the committee, Mr. Levin, for his opening remarks.
Thank you, Mr. Chairman, and welcome to the panel. Since the Affordable Care Act was signed into law 6 years ago, the progress we've seen in health care in this country is undeniable. 20 million Americans who were previously uninsured now have quality coverage they can afford. Health care costs are growing at the slowest rate in more than 50 years. Millions of young adults have been able to stay on their parents' plans until age 26. And nearly 130 million Americans no longer have to worry about being denied coverage or charged higher premiums because of pre-existing conditions. Yet despite these gains, Republicans continue to try to cook up ways to destroy the law. There have been 63 votes in the House to repeal or undermine ACA. That is a dangerous prospect on its own. But when it's paired with the fact that Republicans have come forth with no viable, comprehensive alternative with which to replace the ACA, that's a recipe doomed to fail. Take, for instance, the Republican proposal to eliminate or limit the tax exclusion that employers receive when they offer health insurance to employees as part of a compensation package. This would disrupt the employer-based health insurance system that 155 million working Americans and their families rely on for coverage, and likely would result in many employers no longer offering health care at all to employees. And it would leave many, including employees who are older or in poor health, without the ability to find affordable coverage. Republicans have also proposed expanding the use of health savings accounts, which are associated with health plans that have high deductibles and most often used by wealthier households. HSAs are not an adequate replacement for comprehensive health care coverage, as they can actually lead low and middle-income Americans to put off medical care because they simply cannot afford to pay high deductibles or copays. Repealing the ACA, as Republicans want to do, would have devastating effects for millions of Americans who use the tax credits that the law offers. The advanced premium tax credit and premium tax credit are integral in making health insurance plans in the marketplace affordable for Americans. Unlike a once-a-year tax credit, we chose real-time tax credits to help hardworking American families afford coverage throughout the year. Earlier this year, I met a woman who came down with breast cancer. She lost her job and health care coverage. Because of the ACA, she was able to become covered again with health insurance. Her breast cancer reoccurred, and she made clear to us that this new health coverage, as she said to us, looking at us straight in the eye, saved her life. Saved her life. Stories like these remind us of just how vital this law is. And for that woman, and for millions and millions of people in this country, the Republican alternative has simply been 63 votes to destroy or undermine the coverage that people have received. Now is the time to keep building on this success, not to start over, and to risk losing all that we have achieved for millions and millions and millions of Americans. I yield back.
Without objection, other members' opening statements will be made a part of the record. Today's witnesses in the panel includes 3 experts. First, we welcome Joseph Antos, the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. Next, we will hear from Avik Roy, a senior fellow at the Manhattan Institute. Finally, we'll hear from Stephen Kreisberg, the Director of Research and Collective Bargaining Services with the American Federation of State, County, and Municipal Employees, AFL-CIO. The committee has received your written statements. They'll all be made part of the formal hearing record. We've reserved 5 minutes to deliver your oral remarks. We'll begin today with Mr. Antos. Welcome, and you may begin when you're ready. You might try the microphone again.
It turns red.
Oh. There you go.
Okay.
Thanks. You were just following my lead.
It's much too complicated. Thank you, Mr. Chairman and Ranking Member Lemon and members of the committee. I appreciate the opportunity to talk about this very important issue today. I'm going to focus on the problems created by the way that the tax system subsidizes health insurance and the need for Congress to replace the Affordable Care Act's Cadillac tax on high-cost employment-based health insurance with a better approach. First, address the tax exclusion. Premiums paid for employment-based health insurance are excluded without limit from both income and payroll taxes. That reduces the cost of health coverage for the average worker by about 30%. In the aggregate, the savings amount to more than $250 billion annually. While the tax exclusion has made workplace health insurance affordable, it has also fueled the rapid growth of health spending, contributed to stagnating wage growth, and is regressive. The exclusion encourages workers to buy insurance that offers lower cost sharing but higher tax-free premiums. That makes consumers less sensitive to prices and promotes the use of medical services, and some of those services may not provide full value to the patient. I think that's the issue. We have waste in our health system. IOM says 30% of the money we spend is wasted. Compensation also has shifted from taxable cash wages to greater health benefits, which are not taxed. Between 1999 and 2015, the average employer contribution for family coverage nearly tripled, while wage rates increased by only about half. It is likely that many workers, given the choice, would prefer somewhat lower health benefits for somewhat higher cash wages. And then finally, workers with higher incomes, of course, benefit the most from the exclusion. The Joint Committee on Taxation found that average savings for tax filers with incomes less than $30,000 was about $1,700 compared to about $4,600 for those with incomes over $200,000. So it's a regressive kind of a tax, kind of a subsidy. We can restructure the tax subsidy to promote better health insurance choices that lead to more efficient, higher value care. The subsidy can be made fairer without eliminating the financial incentive employers have to offer health coverage to their employees, and reforms can free up funds to help stabilize coverage for the 27 million who are left uninsured by the ACA. Unfortunately, the Cadillac tax is not that reform. The 40% excise tax on high-cost health insurance was intended to offset some of the excessive health spending arising from the tax exclusion. It's levied on employers, it's levied on insurers and other health plan sponsors. And the tax is paid on the cost of a health plan that exceeds certain thresholds. Even though it is billed as a tax on insurance companies, workers ultimately bear the burden through lower compensation. Moreover, the tax is regressive. The same 40% tax is imposed on the production worker and the CEO, regardless of how much they are paid in cash wages. They either pay higher premiums or their health benefits are cut back to avoid having to pay the tax. Either way, there's more cost for workers. The tax will eventually impact everyone with employer coverage. The cost thresholds are indexed to general inflation. Healthcare costs rise faster than general inflation. And so ultimately, all employer health plans will exceed what the ACA considers acceptable levels of health care coverage. Simply repealing the Cadillac tax, I think, would be a mistake. First of all, you need to find offsetting budget savings. Second of all, simply repealing would ignore the problems with the tax exclusion and other tax provisions affecting health insurance. Reasonable reform would repeal the Cadillac tax and modify the tax exclusion to produce both budget savings and better incentives for the health sector. Two generic options: tax exclusion instead of the refundable tax credit. To replace the tax exclusion with a refundable tax credit, sorry. Tax credits would break the financial link that motivates employers to offer health insurance and employers to buy it. There still would be a reason for employers to offer health insurance, but the money wouldn't be there from the taxpayer. Money wages can be expected to increase with the loss of health benefit in firms that drop their own plans, although some firms will continue to offer the benefit because it's a recruitment tool. A credit would be a fairer subsidy. The amount of the credit could be adjusted to account for regional variations in healthcare costs, for example. There are lots of ways to design it. It can be very complicated, but fundamentally, it's a better system. Alternatively, we could cap the amount of the tax exclusion. That would give employers an incentive to offer lower-cost plan options, but would not drive employers to offer only low-cost plans. Capping the exclusion is a less dramatic reform than shifting to a tax credit and could be a reasonable compromise that would promote more efficient health plans within the current employer framework.
Thank you, Mr. Antos. I understand that you can be with us till 12:15 today?
Yes.
Great. Thank you very much. Mr. Roy, you're up next. Welcome.
Thank you, Chairman Brady, Ranking Member Levin, and members of the Ways and Means Committee. Thanks for giving me the chance to speak with you today about the tax treatment of health care. In my remarks today, I'll focus on three areas. First, I'll discuss how the tax treatment of health care is the central flaw in our health care system. Second, I'll address arguments made by opponents of health tax reform. Third, I'll discuss the principles of sound reform. Republicans and Democrats may occasionally disagree on health care policy, but we all agree that health care needs to be more affordable. Nearly all of the growth in future federal spending and thereby future tax increases is driven by health care, in particular health care inflation. And the high and rising price of health care is the reason we have so many uninsured. According to the CBO, 98% of the long-term uninsured cite the high cost of health insurance as a barrier to coverage. Only 6% cited poor health status, such as a pre-existing condition. The median worker's paycheck has barely increased in 3 decades, but overall compensation has grown. The problem is that most of the growth in compensation has been eaten up by the rising cost of health insurance. In 1996, the cost of coverage was 11% of per capita income. In 2010, it was 19%, nearly double. The high cost of U.S. care originates in 1940s wage controls, as you know, and is enshrined in the employer tax exclusion. Hospitals, doctors, and drug companies have a powerful incentive to charge high prices here because the exclusion from taxation of employer-based insurance prevents patients from controlling their own health care dollars and thereby holding companies accountable for the prices they charge. Today, the employer tax exclusion, its value in terms of federal, state, and local income taxes and federal payroll taxes exceeds $500 billion a year. So it's extremely important to handle reform of the exclusion with great care. But that's different from opposing reform altogether. If we want to make health care affordable, done properly, we have to reform the exclusion. Health tax reform the right way would put more dollars in the pockets of workers rather than insurance companies. Some opponents of health tax reform say that employer-based coverage protects us from single-payer health care. That is manifestly untrue. The rising cost of employer-based coverage has actually been the principal argument for every major expansion of government-run health care in the United States. Switzerland, by contrast, has a market-based system in which everyone purchases private coverage on their own, individually. That system isn't perfect, but it's been a far better check on the government. In 2014, the Swiss rejected a referendum to replace their system with single-payer health care by a margin of 62 to 38%. People like choosing their own plans and will never allow the government to take away that right if they control it. There are two keys to high-quality health care reform, health tax reform. The first is that any reform should give workers more options to buy the coverage that they want. The second is that reform should be enacted gradually. The ACA's Cadillac tax resembles such reform by taxing high-value employer coverage, but that tax contains many exceptions and does not deploy the revenue it raises to aid all those who would like to purchase insurance on their own. The best way to expand health insurance choices for individuals is to truly equalize the tax treatment of employer-purchased and individually purchased coverage. Congress could design a cap that raised an equivalent amount of revenue as the Cadillac tax, gradually phased in over time, while also providing tax relief to those who purchase coverage on their own. There's wide bipartisan agreement on the utility of refundable tax credits for expanding coverage to the uninsured. The ACA, of course, deploys tax credits for this purpose, but that law has imposed costly mandates on insurers and individuals that have made coverage less affordable for millions, especially those ineligible for subsidies. Some say that we should offer Americans an identical tax credit to every American with which to purchase coverage. But such a system would necessarily under-subsidize the poor, the sick, and the vulnerable, while over-subsidizing the wealthy. Tax credits for the uninsured should embrace the best of both worlds. They should be means-tested to best help those in need. They should apply to health savings accounts and maximize the ability of people to choose the care and coverage that's best for them. In this way, we can achieve the goals that every member of this committee shares, ensuring that every American has access to quality, affordable health care. Thanks again for having me. I look forward to your questions and of being of further assistance to this committee.
Thank you, Mr. Roy. Mr. Kreisberg, welcome, and please proceed.
Thank you very much, Mr. Chairman, and thank you, Ranking Member Levin. It's a pleasure to be here today. My name is Steve Kreisberg. I am the Director of Research and Collective Bargaining with AFSCME, a large public employee union in the United States. And we don't think we can start talking about the American healthcare system without talking about the Affordable Care Act. This is an act that we supported. We have a long history of supporting healthcare reform and expansion of coverage to all Americans. Now, as public employees, virtually all of our members have adequate healthcare coverage, which is a great thing. So a lot of folks have asked us, why would we be supporting the expansion of coverage? In the view of our union, this is a fundamental piece of what it takes to be a developed nation. It's a fundamental part of the American dream is to have health care so you can go on to achieve your full potential. The Affordable Care Act, for the first time, really brings that within reach of virtually all Americans. We've expanded coverage. Ranking Member Levin referred to the figures. Unfortunately, we didn't expand it as much as we should have, or we intended to, because 20 states still refuse to extend Medicaid coverage to their citizens. We think that's a mistake, and we think over time we expect to see further expansion of Medicaid. But our members are also very much focused on cost, and like the other two panelists before me, we recognize that cost in our system is something that must be addressed. Under the Affordable Care Act, we've seen a moderation of cost increase year over year. This is a trend that we're pleased to see. Cause and effect are often difficult to determine, but we believe the Affordable Care Act has gone a long way in helping us achieve the cost moderation that everybody seeks. But it's not enough. We all know there's plenty of work to be done, not just with expansion of coverage, but also on costs. And we think the Affordable Care Act and the Obama administration have made a pretty good start in this regard. The most important aspect of this, in our view, is the alignment of financial incentives to achieve quality and value in our healthcare system. We think the problem of cost is on the supply side, not on the demand side. And I think that's very important as you consider the issues in front of you. I think what Mr. Roy was implying in part is that we need to change consumer behavior, and that will lead to a reduction in our healthcare expenditures. We don't have faith that that will be an effective solution to our problems. We think the problems of our healthcare system is that we do not have a free market, and we never had a free market in healthcare. It doesn't operate like other markets. So we need to align incentives from the payers, who are not individual consumers for the big ticket items, but through our insurance companies and from our government. And by that we mean that we have to move away from the fee-for-service system, and I think there's universal agreement that that's probably a wise approach, and we're starting to do those kinds of things right now. We also feel we need, and this is part of the same approach, to further expand access to primary care and embed primary care with their other avenues of care. So we're not running into specialists uncoordinated from primary care providers. We also must address prescription drug prices. They're accounting for the large part of our trend in cost increases. Every other developed nation, including Switzerland, regulates prescription drug prices. We don't do so here. We should consider that or some other alternatives to help bring our prescription drugs under control, and we expand on those remarks in our written testimony. I do want to talk a little bit more about the tax exclusion. The foundation of our healthcare system right now is employer-based coverage. We believe changes and caps to the tax exclusion undermine that. In fact, we believe changes and caps to the tax exclusion will have the same aberrant results of the excise tax, which the two panelists oppose. So we cannot figure out how you can reconcile the position on tax exclusion with the position they take on excise taxes. We think both will have the unintended consequence of shifting more cost to consumers. Now, some consumers may prefer high deductible health plans. When you're young and healthy, you do. But those very same consumers hope to get old because it beats the alternative. And when they get old, they're going to want more comprehensive coverage. So we're going to see people perhaps enjoy high deductible coverage when they're younger and healthier, but eventually, as age catches up with them, opt into the higher cost plans and the more comprehensive coverage. That makes no sense. Everybody should have comprehensive coverage from day one to keep our risk pools intact. We believe the high deductible plans are not the effective way to reform healthcare. In fact, if you ask your constituents what the problems are with the American healthcare system, I don't think any of them will say the problem is that they don't pay enough. I think they believe the problem is they pay too much. Thank you very much.
Thank you, Mr. Kreisberg. We'll now thank you for the panelists' opening remarks. We'll go to the question and answer period, and I'll begin myself. I've said it in the open. I want to be perfectly clear. Most Americans get their health care at work, more than 150 million Americans. We're going to preserve incentives to get health care at work. But the world's changed. And the question is, can we create flexibility and expand and make equal that tax incentive so that Americans have more choices? Mr. Antos, do you believe we can create, sort of modernize that tax exclusion at work in a way that creates flexibility and keep the importance and the incentives for health care at work? Can we do both?
Yes, I think we can. As I mentioned, if you cap the exclusion, that doesn't mean you remove completely the tax subsidy through through employer-sponsored coverage. But what it does do is it discourages the purchase of very expensive coverage that tends to have very low cost sharing and which prevents people from understanding what the cost of health care is. I mean, the fact is that health insurance through the employer is kind of a mystery to most people because the premiums are taken out of your pay. You don't often know what your premiums are, and the employer contribution is also a mystery. People think that it's not coming out of their paycheck.
Yeah, and it is. Mr. Roy, we talk about the tax code being stuck, in the past because it's been 30 years since we reformed it. But this tax incentive actually first appeared in 1918, got serious 70 years ago, and effectively is stuck there. But workers aren't stuck. Many of them change jobs multiple times throughout their life. Many will go home to start a small business. Others choose to want health care individually so they can raise their families. How, in your view, is it appropriate to modernize that tax incentive at work to be able to create that flexibility for workers to live a 21st century life because, frankly, their lives are different than when this first got serious 7 decades ago?
Absolutely. I would make 2 points. The first point is that employer-based tax reform or health tax reform is not about having workers pay more. It's actually about workers paying less for their health care. All of these efforts are about making sure that workers pay less for health care and that health care is more affordable in the future than it is today. And the second point that I'd make is that what's really important, aside from making health care more affordable, is putting patients and workers more in control of their own health care dollars. Today, those health care dollars are controlled by the government, by employers, by insurance companies, by hospitals, by drug companies. They're not controlled by the consumer, by the worker, by the patient. And all of our efforts on tax reform are about putting the control back in the hands of that individual and those families.
Well, can I follow up with that? And that's sort of my final question. I may have another after that, but this is really about in a world where most people are told, here's your health care, you'll like it, just take it or leave it, we'll decide what's best for you. This is about actually giving consumers control, picking a plan that's right for them, not what Washington wants, not what someone else wants, and what they need for their family and their lifestyle. It seems to me in the 21st century, what we need armed through life is a healthcare backpack. It includes a health plan that works for you and can travel with you, whether it's to another job or home or to start your small business. You need a health savings account to be able to better afford the day-to-day costs of health care and prevention. And you need easy access to your medical records so you can share that with a doctor or an emergency room if you're traveling at the time. It seems to me that how we modernize, how we get health care work actually creates that flexibility for Americans. So, Mr. Antos, your view, what's the best way to modernize this tax incentive at work, and Mr. Roy as well, that creates that flexibility for Americans to control more of their health care plans?
Well, I think the question is what are the real bounds here? In the sort of ideal world, I think you would definitely go to a tax credit type of a subsidy, which would free workers to buy the kind of coverage that they want on the individual market. That would, of course, require some additional health insurance reforms.
In that case, you would keep the tax incentives at work, but you'd have an option for the first time really ever, an option to take that, equalize that tax credit, and make some choices.
Right. I think the key principle is to make it possible for people, wherever they buy insurance, to have the same level of support.
Yeah, sort of equal treatment. Mr. Roy?
Yeah, I would agree with my colleague over here, Mr. Antos, and I would add that one of the important things about giving people that choice to buy the health insurance and the health care that makes sense for them is the profound innovation it would trigger in the healthcare system. Today, in most states, one health insurance company has 80% of the market. And that makes it very, very difficult for people, even if they do choose their own health insurance, to have true choice. But if you actually give people control of those healthcare dollars again, give it back to them to spend the way they want, you'll see profound innovation and competition in not just how health insurance companies have to compete with entrepreneurs, but also how health insurance should be used versus health savings accounts, versus urgent care, versus all the other things that are out there. So people should have those choices, and we won't be able to anticipate how the consumers, how individuals will decide to use those dollars in the future, but it will be much better than it is today. That we can be very confident of.
Well, thank you, because what we have isn't working in the Affordable Care Act. Here's the number of people in the Houston region that get cancer under Obamacare can go to MD Anderson for the best cancer care in the world, 0. This number of PPOs that are now available, it was 0, by the way, that are available in our part of the world for families under Obamacare. And I can't count the numbers of the extra dollars out of pocket that people pay now in the exchanges under the Affordable Care Act that they can't afford. In fact, in Texas, half the people who are supposed to be forced in Obamacare have elected to pay a tax than to go into a health care plan they don't want and can't afford and can't see the doctors to get the medicines they want. So we ought to be thinking about a 21st century option for the first time ever that recognizes what people need, not what Washington needs. With that, now recognize the distinguished ranking member of Michigan, Mr. Levin, for any questions he may have.
You know, I want to be polite, but let me just say this. I think the Republicans have failed. This mic doesn't. Yeah. The Republicans have failed for 5 years to come up with a plan because there's so much double talk. You say you don't want to eliminate the exclusion, but then you want to come up with a tax credit and give people control of their health care. Essentially, if you think it through, what you want to do is to replace employer-based health care coverage. you don't say that, you kind of modify it. The Cadillac thing, modify it. So you've been handcuffed because you just talk out both sides of your mouth constantly. And listening to the two of you, I don't know what your plan would ever be. You say, keep the exclusion, but cap it. And then come up with credits. You don't say how much. If it's enough, employers won't provide health care anymore. You're going to destroy the basis upon which we've built. You can talk about 100 years ago, but this started after the Second World War when employers began to provide health care coverage, and it spawned for the first time most people having health care coverage. And you talk about Switzerland. I want to say this politely. This is not Switzerland. This is not Switzerland. Do you favor continuing Medicaid, yes or no, Mr. Antis?
Sorry, continuing Medicaid?
Yes.
Yes, I favor continuing Medicaid, but with substantial reforms.
You favor continuing it?
Mm-hmm. We have to help poor people have access to appropriate health care.
Medicaid provides coverage for more than just poor people. Mr. Roy, do you favor continuing Medicaid?
Yes, if you want to know all about the details of my own views on health reform and how to achieve universal coverage, I've published them at the Manhattan Institute.
Okay, I understand that, but you favor continuing Medicaid?
Yes. What we need to do, though, is dramatically reform Medicaid, because right now, health outcomes for people enrolled in Medicaid are no better than people with no insurance at all, and that's because the system is so poorly designed. So reforming Medicaid is essential to providing high-quality health coverage to the poor.
So health care under Medicaid is no better than for people who have no health insurance at all?
According to the New England Journal of Medicine, which published a study looking at Medicaid enrollees in Oregon, people enrolled in Medicaid showed no better health outcomes than people with no insurance at all.
They were talking about outcomes. That was one study. That doesn't mean that people...
There are many other studies.
Okay, that people who have Medicaid are no better off than people who have no insurance at all.
Well, just to be very clear, I support universal coverage. I support health coverage for the poor. I think we should do it in a very different way.
Mr. Kreisberg, talk a bit, if you would, about this notion giving people control over their health care.
Well, you know, as I indicated in my statement, the healthcare marketplace simply does not work the way other marketplaces work. When somebody has a disease, they're often in the hands of their trusted physician, who will direct them to a lab for tests, direct them for a hospital for services. What we have now in terms, we group people, and we group them in insurance plans, we group them in self-insured plans offered by employers, and this grouping mechanism provides the ability to negotiate with the provider. At the time that I'm diagnosed with cancer, I'm not in a position to start shopping around and negotiating with various hospitals who may or may not even give me the time of day in those negotiations. Those are the big ticket items in healthcare. We're not talking about a doctor's office visit when I have the flu. Those are not the issues that are driving our healthcare cost increases. So we have to start from the premise that consumers are not empowered in a healthcare marketplace, and they will not be, regardless of what we do. I think Mr. Roy talked about the fact that there's a monopoly in some states among insurers. How would one individual be able to negotiate with a monopoly? How does that plan, if you will, deal with the issue of a monopolist? We're better off with large employers and self-insuring to create some competition.
Thank you. All time has expired. Mr. Johnson, you're recognized.
Thank you, Mr. Chairman. Mr. Antos, I have a few questions, but I'd ask if you would just answer yes or no.
Sure.
First, isn't it true that about 155 million Americans receive health insurance through their employer?
Yes.
Next, you stated that the average employer contribution to health care has grown faster than wages, but haven't health care costs also grown faster than inflation?
Yes, absolutely.
Now, you also testified that workers would likely prefer lower health care benefits in exchange for higher wages. But depending on how Congress caps a tax exclusion, couldn't the employee end up paying even higher taxes?
It's possible. The details do matter.
Lastly, your testimony cites a study showing that 30 cents per dollar is wasted, which includes increased spending from consolidation. Do you agree that Congress should also address these issues?
I think the health system should address the waste in the health system. That's where the solution is going to be. Congress can help by passing reasonable laws, and HHS can help by interpreting them in an appropriate way through regulation. But ultimately, it is up to the health system to solve these problems.
Well, we always try to pass reasonable laws. Your answers clearly show that Congress must be very careful, though, with any changes to employer-provided coverage. The bottom line is that employer health insurance has worked for over 60 years and provides affordable, quality insurance to over half of all Americans. We also can't lose sight of the importance of promoting free market ideas to reduce costs and increase access, things like FSAs and HRAs and my bill to allow employers to band together to purchase insurance. I also think this committee should take a serious look at repealing Obamacare's anti-competitive prohibition on physician-owned hospitals. Mr. Chairman, I yield back.
Thank you. And Dr. McDermott, you're recognized.
Thank you, Mr. Chairman. If Tip O'Neill were here today, he would say, well, this is another smoke and mirrors hearing. You blow smoke up in the air, hold up a mirror, and let people see whatever you want. It's been 6 years since we passed the Affordable Care Act. We hear rumblings from time to time that the Republicans are about to have a replacement plan, somehow achieving the goals of ACA by tearing it apart. Now, the truth is, we will never get a plan out of the Republicans any different than ACA. In the 6 years, there hasn't been a coherent plan. In spite of all our attempts to repeal and everything else, they never put anything on the table in writing. It's all smoke and mirrors, folks. There's good reason we haven't a plan. There is no place to go. The few ideas that have floated would create economic and personal chaos. Paul Krugman wrote a piece in the New York Times this week called Obamacare Replacement Mirage, and I ask unanimous consent to have it included in the record. And it describes Chairman or Speaker Ryan's problem precisely. There is no place to go. If you want to cover all Americans and ensure financial security and control costs, you have limited options. One is a single-payer system. I support that, but we don't have that. So I'm supporting what we have and trying to fix it. That cuts the greed and the insurance industry waste out of the program, a single-payer system. The other alternative is to rely on the existing system while eliminating abuses in the insurance industry. And that would mean community rating and guaranteeing coverage for consumers with pre-existing conditions. Because a system like that would require insurers to cover sicker populations, you need a mechanism to balance the pool of people. And that's where the individual mandate comes in. You can't have a pool of just sick people in the insurance plan and have the sick ones out here waiting for the day when they can run in and get their insurance. They all have to be in. Now, if you have an individual mandate, you need to be able to afford the coverage. That's a common sense understanding. So you need to subsidize premiums and you need to reduce cost sharing for lower income people. That's also common sense. In essence, it's the only reasonable alternative to a single payer system looks like the Affordable Care Act. And that's why the Republicans have nowhere to go. They won't fix it. We won't have hearings in this committee about consolidation in health care or on drug prices. You bring up Switzerland. Switzerland has a highly regulated government system that's run by insurance companies. They negotiate the drug prices in Switzerland. We don't allow the government to negotiate the drug prices in this country because this committee won't have a hearing on what's going on with drug prices in this country. Now, if you want to get rid of the individual mandate and keep in place issue for people with pre-existing conditions, you put the insurance industry into a death spiral. We did exactly that in an experiment in Washington State in the 1990s. And we lost the individual market because you can't have guaranteed issue and not have some way to save the insurance companies. Now, if you want to take away American subsidies, that will mean you're going to have financial hardship for everybody, and you will not be able to have insurance because most people can't afford it without either employer help or government help. That's what's going on right now in the ACA. And if you want to continue these hollow efforts to repeal the ACA, what you're saying is one of two things. Either you want to replace the ACA with a single payer system, and I'm for that. I'll sign up today for that. Or two, you don't want to provide health care coverage for the American people, for all the American people. You only want to put it for the financially able American people. The health service savings accounts are for rich people. Poor people don't have those things. They can't use that because they can't pay the deductibles. So you can't have it both ways. And unfortunately, we're having another hearing for this smoke and mirrors business. We won't get it without having adjustments to the Affordable Care Act, because that is the Republican program.
We may need to call on Switzerland to mediate the differences between the Committee on Health Care. Mr. T. Bear, you're recognized.
Thank you, Mr. Chairman. You know, one of the things I love about this committee and my friend Mr. Levin and my friend Mr. McDermott, and I do believe their heart's in the right spot, but you never cease to remind me as to why I'm a Republican. And I appreciate that a lot. Because I do care about people. Everybody on this side of the aisle, like your side of the aisle, cares about people. But it's a challenge for me because Mr. Roy said he is for universal health care. I'm for universal health care. And in fact, in my state, it's probably different in Michigan. We expanded Medicaid, but I run into people every day when I'm back home, whether it's a hospital administrator, whether it's a physician, whether it's somebody on Medicaid or a family member of somebody on Medicaid who can't get access to a primary care doctor because a primary care doctor thinks that Medicaid is flawed. I think that was your point. So, Mr. Levin, Mr. McDermott, to sit up here and say that just because Obamacare passed, everything is well and good and there aren't challenges for people, not the rich, by the way, is frustrating to me. Because what Obamacare also did, at least in my district, maybe not yours, is that people who were excited about it passing were excited also about the president saying, if you like what you have, you can keep it. And I continue to run into people who haven't got to keep what they had and are paying more and getting less, quite honestly. So I get frustrated up here when every time we have a hearing to try to improve the healthcare system for patients, for my mom and dad, and we've talked before, Mr. Thompson's looking at me, with respect to this silver bullet of negotiating prescription drugs and how great that is. Well, my dad experienced how great that isn't. So, and how wonderful Part D, quite frankly, has been. I have an aunt who doesn't have to go to Canada anymore because of Medicare Part D. So, Mr. Roy, the thing that this was supposed to be about was about the tax exclusion. I have a sister who many years ago had a little boy. He's now going to graduate from Ohio State, go Bucks, in a couple weeks. And when he was a little boy, they moved away to Cincinnati, and she came back over the Christmas holiday. He got sick. The former pediatrician gave him a drug to take. During the Christmas holiday, she gave him this prescription. He got better, and before New Year's Day, she threw away the prescription. And I said to her, what are you doing? if he gets sick again, there's still medication left. She said, don't be so cheap. Costs $3. I'll get another prescription. But the point is, just like what Mr. Brady talked about, she's excluded from the true cost of that drug. My mother-in-law had a stroke a year ago. My wife's a pretty smart person. She's an accountant. Everything was focused on where to go after the hospital for rehab, on what insurance covered, not on quality, not on cost. We don't know to this day how much it cost. Now, thank goodness we had good quality, or she had good quality care, but the consumer, the patient, because the system isn't patient-centered, whether it's a Medicaid patient who can't get in to see a primary care doc and ends up in the emergency room in Columbus, Ohio, or my mother-in-law who's going to a rehab facility, the patient is excluded from the cost of the care. How do we get patient-centered care and patients focused on the cost so there's not overutilization, so that there's more transparency, and all of us know that there's just not some tree in the backyard we're pulling money off of, and we don't have any competition.
The only way to have patient-centered health care is for the patient to control the health care dollars. We don't have patient-centered health care today because employers and insurance companies and the government controls the dollar. And that's why we have government-centered health care, not patient-centered health care. I want to bring up a point that was brought up earlier about Switzerland and how it allegedly has regulated prices. What it has is insurance companies can jointly negotiate prices with hospitals and drug companies, and that's a system, I've written about this for Forbes, we could have here. All you have to do is have an antitrust exemption for those kinds of negotiations for private insurers in Switzerland or in the United States. So there are market-based systems elsewhere that we can learn from, but you're never going to have a patient-centered healthcare system unless the patient is controlling the dollars.
And you're for quality health care.
Absolutely.
Thank you.
And again, I've written about this extensively. I would encourage anyone who's interested in a detailed plan on health reform
I yield back.
to download it from the Manhattan Institute or from the American Enterprise Institute, for that matter.
Thank you. Mr. Lewis, you're recognized.
Thank you very much, Mr. Chairman. Thank each one of you for being here this morning. I would just like to know whether you believe in health care as a right. As a right. In a country such as ours, health care for all. Do you subscribe to that idea?
Who is the question addressed to me, sir?
Any of you.
First, let me just say, Mr. Lewis, it's always a pleasure to speak with you. You're a personal hero of mine. I support universal coverage. I think, like many of your colleagues, a country that is as wealthy as ours should strive to provide quality health coverage for every American. But the way to do that is to maximize the degree to which individuals are controlling those health care dollars and subsidize through tax credits, through refundable tax credits, those choices for those who need the help.
Good morning, Mr. Lewis. Yes, our union definitely supports health care as a right, just like it's really a matter of
it's a fundamental right.
A fundamental right to health care is something that we fully support.
I agree with Mr. Roy. I would also make the distinction between health care and health insurance. Just because you have health insurance doesn't necessarily mean you're getting appropriate care. So I think we need to work on both financing and delivery reform.
But if you accept the idea that it is a right in a democratic society such as ours.
Yes, I agree with Mr. Roy. I think I probably agree with everyone in the room that everyone should have health insurance, and those who need support to obtain that coverage should get it.
But do you see the Affordable Care Act as a down payment, as a major down payment for all citizens? It is not perfect?
I'm sorry, you referred to the Affordable Care Act?
Yes.
Well, it's a down payment in a sense, but I would argue for some fairly substantial reforms. Certainly, the idea of
Will you subscribe to the idea that it is a major down payment?
So part of the down payment was to change. I think it's a very important change to change insurance rules so that if you have a pre-existing condition, that cannot be held against you in terms of access to insurance or premiums. I think that's a good change. I don't see us ever moving back from that. But as far as the way we're financing it, as far as the complicated way we're making people try to understand what options they have, as far as the restrictions on what insurance must cover, I think those are things that need to be dealt with.
What would you say to the average person who receiving health care now that didn't have it before? What would you say to them? You should get rid of the Affordable Care Act.
Well, I support reforming the law that exists today, so I would argue that the appropriate reform would, in fact, give everyone access to insurance and give those who need help the most have support from the taxpayer, and that includes the people, obviously, who most of the people who are signing up on the exchanges. Most of the people are signing up because they are getting substantial subsidies. The people who don't get substantial subsidies aren't signing up, which is a major problem with risk selection in the exchanges.
Mr. Crunchyberg, you care to respond to that?
Yeah, well, the first thing I'd say is I appreciate that everybody does join in the idea of universal coverage, and I would ask Manhattan Institute and AEI to join AFSCME in going to those other 20 states so we can adopt Medicaid expansion, so we can really go a lot further in getting to universal coverage, because we have 20 states that don't buy into the idea that it's a fundamental human right and it's a fundamental part of being American to have health care coverage, because they have that opportunity at no cost to the state, and yet they refused to participate in the Medicaid expansion. Now, with that said, I think the idea—
Is that true in many of the states where the Republicans are governors?
Well, yeah, there's Republican governors, Republican legislatures. I don't want to necessarily make it overly partisan, but it is a partisan issue, I suppose. It's ideological. It's ideological opposition to the idea that we're going to have a government program that addresses a real pressing problem that affects real people. We know that a child will not reach his or her potential if they don't have health care.
Thank you. All time's expired. Mr. Smith, you're recognized.
Thank you, Mr. Chairman, and thank you to our witnesses. I want to focus on consumerism in healthcare, because I don't think the American people are offended that there's a suggestion that we should have health insurance. It's that the government is forcing people to have insurance coverage that many would find personally objectionable. And I think it's a good idea to have health insurance. I look back at when I had my first real job out of college. I assumed that the group plan was the best for me, so I didn't shop around. I would later learn that I could have saved a lot of money by shopping around. And so I wasn't the best of consumers then. And I certainly see policies today that discourage consumerism. And certainly discourage, well, prohibit people from exercising what I would call freedom to decide what is the best coverage that would be there for their families or themselves as individuals. So what can we do to encourage more consumerism? And I mean, I don't want to take coverage away. Another concern that I have, and there is this push to expand Medicaid. All the while we know that it pulls people off of private pay in some cases, and Medicaid provides lower reimbursements to hospitals and doctors, and so it becomes this vicious cycle that who loses? Consumers, patients, and drives up the debt and fewer choices that are out there. What can we do to encourage more consumerism? Mr. Roy?
Yes, so again, I would say that the biggest thing that you can do to encourage consumerism is to have the patient control the healthcare dollars. The reason why we don't have an Uber for healthcare, or we don't have the kinds of technological innovations that have changed the rest of our economy, why is that not happening in healthcare? It's because those things can only happen when the consumer can direct his or her dollars to the healthcare service that he or she needs. When the government or the insurance company or large employers control those dollars, then the consumers aren't involved in those decisions. So you have to have the patient in charge of the healthcare dollars, and health tax reform, which this committee is considering, is the central key step to achieving that goal.
Mr. Kreisberg, in your previous comments, you were talking about the overall healthcare issue. Is it possible that there would be a good healthcare plan that would not be drafted or controlled by the government?
Of course.
What can we do to head in that direction?
Well, I think, I mean, I'm in a good health care plan that's not controlled by the government. It's a plan that's in private insurance.
Is it a plan that millions of Americans would not find personally objectionable?
I think the plan that I'm in, I think most Americans would be satisfied with the plan that I'm in.
Okay.
But to be more precise with my answer, Mr. Smith, the plan, we need minimum standards for plans, just like we regulate who can call themselves a physician. We need people to have adequate coverage, because what happens is, if I'm in inadequate coverage, and I now have a dread disease, and this plan doesn't cover me, in our system and in this country, I'm not gonna die on the streets, and that's a good thing. But yet, I've shirked my individual and personal responsibility to have adequate coverage, and now the rest of you are paying for my health care. So that's why we have things like an individual mandate and minimum benefits, essential health benefits, so we can ensure that our plans provide the services that'll keep people healthy and treat them when they're sick, and they're sufficient. We can't just let anything be sold and be told that it's health insurance. Because when consumers shop for these,
but the
we don't
government
know all the intricacies of that.
should tell people what health insurance is, that individuals themselves should not be able to decide for themselves?
I think they can decide for themselves, but I think we need minimum standards. It's just as we regulate many other things in our society. Individual consumers at a point of sale for health benefits have time and again in the individual market been caught by surprise. This is in the old days, before the Affordable Care Act, have been shocked that their plan did not cover certain services. And then they were sick and they weren't covered. Because there's a lot of fine print.
If I may, with the gentleman from Rass,
Yes.
Here's maybe the key point here. If your employer said, here's the clothes you will wear in your personal life, and here's the car you'll drive in your personal life, most of us would say no. But today they say, here's the health care you'll have in your personal life. Just take it or leave it. And the point I think Mr. Smith was making was that why can't we give Americans more choice over maybe the most personal spending they will ever make in their life? And I think that's his point. With that, let me yield back, Mr. Smith, since I took the rest of your time.
No, I think we want consumers with their providers to be driving the bus, not the heavy hand of the federal government. Thank you.
Thank you. Mr. Neal, you're recognized.
A quick comment on the chairman's analysis. I think what he's really saying is that under their plan, you'd have no car and no new clothes. Because when you consider that there were 30 million people,
and no jobs under Obama.
No 30 million people we're going to take that question up right now, Mr. Chairman. There were 30 million people without health insurance, at least. And by all objective analysis, 20 million people have secured health insurance under the Affordable Care Act. Now, we all acknowledge that there have been a net gain of about 14 million private sector jobs over the last, the post-recession period. And all of that net gain in employment has been in full-time work. Reform opponents have repeatedly suggested that the ACA is having an adverse effect on jobs. To date, there is no evidence that the ACA has had a negative impact on economic growth or jobs, and in fact has moderated health care costs, which is generally accepted. But, Mr. Kreisberg, based on your experience and analysis, would you address the point that I've just raised? And I'm going to give you sufficient time to go through it from A to Z, please.
Sure. First of all, I agree with you. I don't think there's any evidence that the ACA has been an alleged, as it's been alleged to be a job killer. I think this is first of all, it's a very, very difficult thing to ascertain, cause and effect. And I think everybody will agree with that. And with all due respect to the CBO, they've been wrong far more than they've been right about everything that they've estimated about the Affordable Care Act. And this is one of those things where they've estimated. But if you read the CBO report carefully, what you'll see is they're not saying that people are losing their jobs. they're saying people are withdrawing from the labor force. There's a reduction of labor supply, not a reduction in labor demand because of the Affordable Care Act, and that's a significant distinction. What we're seeing is people, as they're approaching age 65 but not yet eligible for Medicare and don't feel that they can work any longer, now they have an option not to work. We're also seeing on the margins, for instance, people in the Medicaid program may be reducing hours, which is what CBO has said. We don't know if that's true or not. I think it's really hypothetical. And I think, again, it's very difficult for cause and effect, and it's almost impossible to do the empirical analysis to validate some of the hypotheses that they've made. But we do know that after the fact, you can look back, and we know they've been wrong time and again when it comes to the Affordable Care Act. So I think when we look at labor market effects, we really need to focus on the fact that the Affordable Care Act has probably changed more of the supply factors than the demand from employers. So it's not a job killer in that sense. And I don't necessarily think it's a bad thing if people withdraw from the labor market at the age of 62, 63, or 64. If one of the problems we have in our society is stagnant wages, perhaps a reduction in supply of people who no longer feel they can work will help create a little bit higher wage growth in this country because you have less supply and demand should be relatively static. So I think this could be one of the things that actually help us as we move forward.
Since we have a minute and 44 seconds, Mr. Christopher, would you also, we had a conversation earlier about the role that deductibles play, and I thought that your analysis of that was pretty interesting. Could you give us a quick analysis?
Yeah, in our view, the high deductible health plans are really not where the action should be. And I think when we talk about, the consumer should control the dollars, we're really talking about more consumer payments. And I touched on this in my statement. Very, very few people are responsible for most of our healthcare costs. Those people are profoundly sick. It's not necessarily the same people year after year, but it's episodes of care that drive our expenses. The high deductible healthcare system does not get at that. In fact, what we're also seeing with high deductible healthcare is the trend in healthcare cost increases actually exceeds those of the other plan designs. So we're not seeing any long-term moderation from those high deductible health plans. And ultimately, the shifting of cost to consumers and putting consumers in control of the dollars, we don't see as very effective because the consumer has no ability, none, to negotiate with a hospital. They may be able to choose their provider, and maybe some providers provide better rates than other providers. But the idea is that we have insurance companies and self-insured employers who do those negotiations for us, and they are in a much better position to negotiate with those providers because they represent hundreds of thousands or millions of covered lives as opposed to an individual consumer trying to do the negotiation. So if we're going to drive down costs, we need to keep the groups together. We need large groups, large negotiating bodies, and most importantly, we need to change the incentives in our healthcare system. We need to align our financial incentives with quality and value.
Thank you, Mr. Neal. Mr. Riker, you're recognized.
Thank you, Mr. Chairman. I'd like to echo the statements of the chairman and my colleagues about the value of employer-sponsored health insurance. The current exclusion is an important part of why so many of my constituents enjoy quality health coverage today. Employer-based coverage is not only popular, but businesses in my district absolutely need it. We've heard today, however, there are some issues surrounding the exclusion. Obamacare took one approach to tackling this through the Cadillac tax, and unfortunately, Obamacare got it wrong. It's crude, it's complex, and it's flawed policy. And there is bipartisan support for its repeal. So I'd like to look further at some of the shortcomings of Obamacare's approach through the Cadillac tax. So Mr. Antos and Mr. Roy, does the Cadillac tax currently adjust for healthcare costs that might be higher simply because they are delivered in a place with a high cost of living?
No.
Same answer, I'm assuming?
No, yes, actually it does. The Cadillac tax is designed to have a certain band in terms of its thresholds based on health costs in a particular area.
Okay. Well, I don't think it does either. I agree with Mr. Antos. And
Right.
how might Congress better address, though, these geographic variations? And there is a variation in cost of living that should be, I think, considered. The cost of health care varies throughout the country. how might we address these geographic variations in future reforms, Mr. Antos?
It's a difficult question. Obviously, the part of the solution is to reduce some of the unnecessary regulations that are keeping costs up. States are part of the problem, not part of the solution in many cases. But beyond that, we need to have the kind of coverage that promotes a close relationship between the consumer and the insurance company. I agree that the consumer is not going to negotiate individual prices with the hospital. That is the job of the insurance company. But right now, the insurance company really doesn't see the insurance, the driver of this as their consumers. They're being driven by government regulation and the relationship to employers. So we need to turn that around so the consumers are more in charge in that practical sense.
Another major concern is that employee contributions to their health care through an HSA are counted toward the cost of care that is measured against the Cadillac tax threshold. Likewise, spending on wellness is also counted. Can you tell me why?
This is one of the major design flaws of the Cadillac tax is that it's designed effectively to prevent people from having more consumer-based health insurance plans. HSAs are inhibited by the Cadillac tax. As you noted, wellness programs are somewhat inhibited. And also there are a number of loopholes and exceptions in the way the Cadillac tax applies to different constituencies, different employer groups, and different areas of the country. So it would be much cleaner to have a gradually introduced cap on the employer tax exclusion, as some others and we have discussed today, so that it's a simple system that applies fairly to everyone. The challenge is if you heavily vary the tax deduction or the tax exclusion based on particular regions of the country, you might actually have the perverse consequence of rewarding high regulation states that drive up the cost of insurance in their states because they don't face the tax consequences.
Do you have any idea why it was designed this way?
I wasn't in the room when the Affordable Care Act was designed, but I understand that various interest groups lobbied for exceptions and changes to the Cadillac tax so that it could serve their interests better.
Mr. Antos.
So one other aspect of this, I think that the philosophy was that we didn't want to have any leakages. So we're going to include these other health-related benefits to count the costs. It was basically trying to keep everything in the same corral and not have leakages that would have employers, for example, subsidizing health savings accounts more fully.
Thank you. You're back.
Thank you. Mr. Bracero, you're recognized.
Thank you, Mr. Chairman. Gentlemen, thank you for your testimony. Let me see if I can run through a few areas. And first, Mr. Antos, to you, Mr. Roy. I understand you all have put together the elements of a plan that could be an alternative to the Affordable Care Act. Have you asked that that be placed in legislative writing so we could actually see it as a form of a bill?
It's a plan. There's two plans. There's a plan that Mr. Antos and I collaborated on with some other colleagues that was published by the American Enterprise Institute. I think there were 10 co-authors, if that's the plan you're referring to. Then there's the one that I published through the Manhattan Institute individually. Neither of those plans has been introduced as legislation or put in legislative language, but our hope is that it may happen at some point.
Do you have any supporters on the Hill, on the House or Senate side for either of those two plans?
I think that a lot of the general concepts are being considered in a lot of the working groups that the Speaker has organized.
So we're 6 years past the enactment of the Affordable Care Act. We were told by those who objected to the Affordable Care Act, didn't vote for the Affordable Care Act, that we need to repeal it, get rid of it, and replace it. We have yet to see a proposal in legislative language that's been able to garner any kind of support that could pass to replace the repeal of the Affordable Care Act. And I'm wondering if you Can you name any member of Congress who is ready to endorse by submitting your plan into legislation?
What I would say is that
No, let me can you name me a member in the Senate or the House who's prepared to endorse?
I'll volunteer.
I'm sorry?
I'll volunteer.
Okay, so Mr. Price is willing to introduce your plan. So you've got a taker. Will you submit it to Congressman Price so he could submit that into legislative writing?
Sure. More than happy to work with Dr.
Great.
Price.
It'll be so this way we can actually have something to compare, because we'll need to have the Congressional Budget Office, Joint Tax Committee, everyone do the analysis so we can see what we're talking about, because until then we're talking apples to oranges. We want to see what your apple looks like. We see what the Affordable Care looks like. 20 million Americans today, as a result of the Affordable Care Act, have health access, health insurance. And I think for those who kept saying that it was going to cost us jobs, in the time that the Affordable Care Act has been in place as a law, we've had close to 1.7 million Americans go to work or go back to work, not overall, just in the healthcare sector. Overall, some 14 million Americans have gone back to work. So it's going to be interesting to see what your plan, once it's scored out, really shows us. And I hope,
Would the gentleman yield?
Certainly a yield.
Dr. Price, I'd like to join with you in co-sponsoring this fictitious plan that has been out there for 6 years. And if it can really help the Republicans to come up with something, Mr. Roy, would you contact my office and Dr. Price's office so that we will get some legislative language to know exactly what you're talking about?
That'd be great. I want to reclaim my time. Mr. Roy, you could talk to Mr. Rangel afterwards. I want to reclaim my time so I can ask a couple more questions. Mr. Antos, Mr. Roy, so I suspect your plan, I've seen some elements of it. So high deductible with HSAs, you're trying to make them a little bit more robust. Those are parts of what the plans typically include? Well, I'm not trying to name everything. I'm just...
You could choose high deductible plans. So the key element is
I don't want to get into all of it, but I just want to make sure it does rely to some degree on high deductible plans?
No, that's not correct.
No. Okay, I apologize. Do you support high deductible plans?
As a choice, yes.
As a choice. Okay, and let me ask this. Would you support high deductible plans with access to an HSA, health savings account, because that typically is the way they are packaged, right? So you can make the most use of them. For seniors under Medicare?
Yes, I think that's a feasible possibility, too.
Okay. Mr. Roy?
Yes.
Okay. Final question. I think Mr. Kreisberg answered the question about whether you believe health care is a right in this country for Americans. I don't think I heard you say yes or no. If it's not a right, then it's obviously then a privilege that we can try to get access to. Do you believe it's a right?
Yeah, let me tell you a story that
No, I don't have time. I got 11 seconds.
Because healthcare is
no,
a right,
I don't have time for a story.
You have to
could just say, Mr. Roy, if you don't wish to answer the question, that's fine.
Yeah.
But I just asked a question, yes or no?
I refer you to an article I wrote for Forbes called "Yes, Healthcare is an Individual Right."
Mr. Antos?
Yes. All time has expired.
Mr. Chairman, if I could just ask him to answer the question. Mr. Antos,
thank you, Mr. Chairman.
Mr.
Chairman, I believe I have the time now.
Mr. Chairman, could I get just 5 seconds so that the gentleman could answer the question?
Chairman, I believe I have the time.
I will. I'll tell you what, another member can ask that question, or perhaps you could submit the answer in writing.
Yeah. Thank you.
Dr. Rustani?
Thank you, Mr. Chairman. Prior to coming to Congress, I was a cardiothoracic surgeon, had extensive clinical experience over many, many years, and really got to know our healthcare system with all its warts and good things about it at a very intimate level. And now I've had the benefit of serving on this committee and understanding all the policy ramifications and how we deal with the problems inherent in the system. And I could certainly talk for hours about this, but I do want to dovetail off of what my friend from California just talked about when he asked a very, I think, artificial question about creating a dichotomy. Is it a right or is it a privilege with regard to health care? Actually, it's neither. It's a personal responsibility. Nobody can be responsible for my health other than me because there are different dimensions to health care. Yes, you need all the care, you need the coverage, but what's missing right now in our healthcare system today is the fact that individual responsibility and education and information is missing. And that's one of the reasons we don't have a good functioning market in healthcare. That's one of the reasons I like HSAs and other patient-driven forms of coverage that lead to an informed consumer of health products that get us to where we need to be. And I was very pleased. I heard the testimony before I had to step out for just a moment. And Mr. Roy, you talked about equalizing the treatment. And that's what's been missing in all of this is equalizing treatment and let people decide what's best for them. You cannot get to high-quality, low-cost health care without a robust doctor-patient relationship. I can tell you from personal experience, clinical experience, spanning over many years in my life, both here and in clinical practice, we've got to inject personal responsibility into this. Otherwise, we cannot save on the front end with, and I mean, some of the issues with Medicaid, again, it doesn't lead to a meaningful doctor-patient relationship. The access is very severely inhibited. So I think let's explore this concept a little bit about the injection of personal responsibility. Mr. Roy?
Healthcare is a right, and what I mean by that is that it's the right of individuals in this country to choose the health care that they want, to choose the health coverage they want, to choose the doctor they want, the nurse they want, the form of urgent care that they need. Those rights have been abridged by Congress over an 80-year period. And if we believe that health care is a right, then we have to maximize the ability of people to control their own health care dollars, not the government, not insurance companies, not employers.
Thank you. Mr. Antos, you want to comment?
I completely agree with Mr. Roy. The distinction between personal choice and personal responsibility is often overlooked. You need both.
Thank you. Mr. Kreisberg, you want to comment?
Yeah, I think I agree in some respects, but I think where we part ways is this idea of personal responsibility, because we also buy into
Isn't that the American way of doing things?
Let me finish, please. Because we agree with personal responsibility, and I think the approach that my colleagues here take discards personal responsibility. Because personal responsibility connotes adequacy of coverage. So the government mandates that we sometimes criticize and rebel against are really just providing a basic standard. Because if I have inadequate coverage, because healthcare is a right, I am still going to get treated. We have a law, and TALA will take care of me.
But it's not the most efficient, high-quality way. And the problem that you're overlooking in all of this, coverage doesn't necessarily equate to high-quality care. And that is a fundamental problem in our healthcare system today, because whether it's the Medicaid or Medicare system increasingly, those individuals don't have access to a high-quality doctor-patient relationship. It's in the emergency room, it's treatment after the fact, much later in a disease process. I can tell you from years of clinical experience, you've got to establish a high-quality doctor-patient relationship on the front end. Coverage is important, but there are two sides to that equation. There's what the doctor does and recommends, but there's also the personal responsibility element and informational element for the patient. And you can have the very best surgeon or a physician caring for a patient, but if there's no element of personal responsibility or even a diminishment in that level of personal responsibility, you're not going to get a good outcome. So you have to empower individuals, and that fits into our American system of economics, economic freedom, individual liberty, and informed consumers. That's what's missing in our system. I yield back.
Thank you, Mr. Dock. You're recognized.
Thank you very much, Mr. Chairman, and to each of our witnesses. Mr. Kreisberg, I believe you are the first witness to appear in front of our committee in some time to raise the issue of exorbitant pharmaceutical prices. It has been a concern of mine. I think it's appropriate to raise this morning because high pharmaceutical prices are taxing to the American people. In fact, I think they're overtaxing. Mr. Chairman, I would respectfully ask that we make part of the record a letter sent to you back on November 5th requesting a full committee hearing on prescription drug pricing from 10 members of our committee.
Without objection.
Mr. Chairman, that letter emphasized the dramatic impact that high prescription drug prices are having on so many American families, and the tremendous financial hardship to not only get a diagnosis of cancer or some other dread disease, but to face a prognosis of personal financial ruin for many drug treatment programs that are exceeding $100,000 a year. It also pointed to the big impact on taxpayers of the increased costs for public health programs in Medicare, in Medicaid, and other programs because of rising prescription drug prices. And while much of the attention back at the time the letter was written centered on an increase on one particular generic drug from $13.50 to $750 overnight, this is not about one pharmaceutical or one type of pharmaceutical. As you point out, Mr. Kreisberg, in your testimony, this is not just about brand name pharmaceuticals or generics. It's a systemic problem of which there are many aspects, and you pointed to some of the solutions that might be raised. I would just like to see our committee and this Congress recognize that there is a serious pharmaceutical price problem and begin to look for some answers rather than simply to ignore the problem. You made reference, Mr. Kreisberg, in your testimony to the work that the AARP, the American Association for Retired People, has done on this. In February of this year, since the November letter that we sent requesting that this committee focus its attention on this matter, AARP put out a report that noted the average cost of a year's supply of a prescription drug has doubled in just the last 7 years. It talked about the incredible set of price hikes that have been occurring and referred to a Kaiser Family Foundation study that said that almost half of sick Americans, of people that were not in good health, said they were having serious trouble in paying for their medications. We see year after year prescription drug prices soaring far in excess of the level of inflation. Among the suggestions that you've made, Mr. Kreisberg, is that we recognize that there's not true competition, that the marketplace does not work for some brand name pharmaceuticals. I believe there is already a remedy under existing law through a law that was written by Senator Bayh and Senator Bob Dole that would give, when taxpayers have funded the research, would give the National Institutes of Health an opportunity to say, if the price has gotten so exorbitant, then we're going to let competition try to bring it down by licensing to competitors. Do you believe that when taxpayers pay for the research that leads to a new pharmaceutical, that we have a stake in the price that consumers will ultimately be charged for that pharmaceutical, and that the administration should be asserting its rights?
Yes, sir. I absolutely do believe that if the taxpayers have funded the development of a prescription drug, there certainly should be a fair return to the taxpayer. I think we have to recognize, for those of us who believe in a free market system, that one of the biggest interventions and impediments to free markets is intellectual property rights. So if we withdrew intellectual property rights, I mean, that interferes with the free market. Now, no one is advocating that completely, because we do need to fund research and development costs. But in the case you're talking about, if the NIH or some other government agency has funded that research and development, certainly the benefits of that should flow to the American people who paid for the research associated with the brand name drug.
Thank you.
Thank you. Thank you, Mr. Doggett. Mr. Roscom, you're recognized.
Thank you, Chairman Brady, for initiating this hearing. You know, it's interesting to listen to the back and forth a little bit, and let me put this into a little bit of a context. In his opening statement, the ranking member talked about a constituent where the Affordable Care Act, she said it saved her life. I have a constituent who had a different experience, and her experience was she relied on the President's promises that if you like your doctor, you get to keep your doctor. If you like your coverage, you get to keep your doctor, or you get to keep your coverage. And that her experience was, as a 9-year breast cancer survivor, she found herself very happy with her health care and completely turned around as a result of the Affordable Care Act. So we can go back anecdote for anecdote, but I think there's a restlessness that's out there. And it was interesting to listen to you, Mr. Kreisberg, about some of the things that you were pointing out accurately. We've got problems as it relates to primary care. I don't know if you said this, but I'm thinking this. We've got problems as it relates to increased coverage for people. And yet those were all promises that the Affordable Care Act were going to remedy. Remember, it was, hey, there's going to be all this primary care coverage, ERs, you're not going to have to see people, and yet none of that has turned out to be true. So it was oversold, it has underperformed, and it has created a national restlessness. I would argue a restlessness that cost the majority for the Democratic Party, God bless them, the House of Representatives, and it cost them the United States Senate. And what was interesting about the reconciliation bill a couple of months ago was it was the first time that it became clear to the American public that there's only one office that stands between them and the repeal of Obamacare, and that's the White House. That's really interesting, and it's a long-term trend, and it's a restlessness that the country is articulating. Now, Mr. Becerra makes a fair point, and his point is, hey, we know you don't like the bill. You've been very clear that you don't like the act. Where's your replacement? That's a fair criticism, and it's a fair admonition, and I accept that. So I think what the chairman is trying to do, and I know what Speaker Ryan is trying to do, is to do the prelude work, because it's been very clear that the president will not sign something. It's orthodoxy for him. So rather than bumping our heads up against the wall, let's instead try and do the robust work now. It also seems to me that sitting back and listening to the totality of the debate is there's nobody that's really defending how we got here with this large employer-based system. And there's a general recognition that there's two things that are really wrong with our healthcare system. One is it's too expensive, and it is irrationally expensive, and many of the cost drivers aren't making anybody healthier. And the second thing is we as a country are essentially now scandalized by the notion that people with a pre-existing condition wouldn't have access to coverage. That bothers just about everybody. And I think the weakness of the Affordable Care Act was rather than focusing in on those two core themes and really attacking those, around which there was largely a national consensus, the decision was made, and it's the president's prerogative, he was the president, to go a different direction. But I think in our democracy, and I've used this phrase now a couple of times, this restlessness, this level of anxiety. So I am heartened by the notion that today we're talking about how it is going back to wage and price controls after 1945. That's an interesting thing, because you can contrast, and all three of you agree that we don't have a health care market like we have other markets, but yet look at other insurance markets. Other insurance markets are completely rational. They are rational. Why? Because if you have auto coverage, you can change, you can move, it's flexible and so forth. And yet the brokenness that came in as a result of the wage and price controls created a distortion. So I'm listening to this morning. I'm learning from all three of you in terms of your perspective, and I think that there is something significant that's going to be happening in healthcare because the country is demanding it. The country with Obamacare has oversold, and it has grossly underdelivered. And God bless my friends on the other side of the aisle who find themselves in the awkward position of having to defend every bit of it as orthodoxy, when I think if you scratch underneath the surface, they'd say, yeah, it really does need to be improved. And there's nobody that wants to go back. That's also a straw man argument. Like, let's go back to the old days. There's nobody that wants to do that. And so I think what the chairman now is trying to do is say, let's move forward. Let's have a discussion about it, but I appreciate the historical context in which you're putting all this. I yield back.
Thank you. Mr. Thompson, you recognize.
Thank you, Mr. Chairman, and I want to thank all the witnesses for being here. There were a couple of things that were mentioned early on I just want to address right up front, and there was some talk about the government-controlled socialized health care and Obamacare, and was kind of grouped somewhat together. I'm one of those people who have had my health care, received my health care from both the government-controlled socialized health care, and that's when I was in the Army, And now I get my health care, as all members of Congress do, from Obamacare. So I've got a little bit of experience from both. And I can tell you that I use my government-controlled, socialized health care. I was wounded in Vietnam and spent a lot of time in about 5 or 6 different Army hospitals. And the health care, as you point out, I didn't have a lot of choice. You show up and you get what they give you. But I got good health care. But the idea that Obamacare is somehow the same and it truncates your choices, I think is a real stretch. We all have choices. We're all members of, we all get our health care through Obamacare, and we have choices in the private sector as to what health care we purchase. And I'd like to ask unanimous consent to have this list put into the record as a list of 54 choices that, that those of us who buy our health care through Obamacare have when we sit down to decide which one it is we're going to purchase. And I think it's important to note that we do have those choices, and in this case, for those of us on the dais, and it's 54 different private sector plans from which to choose. Mr. Chairman, I'd like unanimous consent to have this submitted in the record.
Without objection.
Thank you very much. I also want to just point out, and it's been said a couple of times, that 20 million more people have health care today because of the Affordable Care Act or Obamacare, and I don't think that can be overlooked. We know also that because the Health and Human Services just let this information out, that Medicare saved $473 billion between 2009 and 2014 because of the lower growth rate in health care. And that's significant for all taxpayers and all Americans. Someone brought up the Tip O'Neill, and the other thing that Tip O'Neill said is all politics are local. And in my home state, the local part, the premium growth rate slowed from 2011 when it was at 9% to 4% last year. That's significant. That means something to people. And in my district, the uninsured rate went from 15.9% in 2012 to 9.8% in 2014. That's about 50,000 people in my congressional district who, because of Obamacare, have access to health care coverage today. They didn't have it before. It's good for them, and it's good for taxpayers who were subsidizing any health problems that they had prior to that happening. And so I think those are all good things. The other thing that I want to mention is one of the folks on the other side talked about now they want to do the work. It's been pointed out a number of times. We've been doing this for 6 years. And the only work that's been done by my friends on the other side is to repeal this health care access that people didn't have before. And to say we want to do the work now, you know, it's about 6 years too late. But I don't think anyone on either side on our side has said that we think it's perfect. We've all recognized there are problems. We've all recognized that we're willing to work to try and fix some of those problems. We could fix the family glitch. We could work on the advanced premium tax credit so people who live in high income areas are able to get health care similar to those who don't live in as wealthy area. Mr. Bustani and I have legislation regarding the health reimbursement accounts. They work. We shouldn't penalize people for using those. What we all want to do is make sure people have health care. And just because one particular access point isn't within the law, we shouldn't ignore that. We should figure out how to bring it in the law. So I would hope that my friends on the side of the aisle are honest in what they're saying, that this is a means by which we can figure out some of these problems and work together. We are ready to work together. Let's fix this thing. Let's improve it. Let's find out where the glitches are and close those up.
Gentleman's time has expired.
The nonsense.
Thank you. Ms. Jenkins, you're recognized.
Thank you, Mr. Chairman, and I thank the panel for being with us today. One particular issue that I've discussed here in committee before, and I'd like to bring up in the context of this hearing, is that of consumer direct accounts, such as health savings accounts and flexible savings accounts. These types of structures allow individuals to make their health care choices while incentivizing them to be financially prudent with those decisions. And in Kansas, along with the whole U.S., these accounts are increasing in number every year. For example, in 2010, there were about 82,000 HSAs in Kansas, and in 2015, there were over 134,000 accounts, an increase of over 60%. Mr. Antos, are you familiar with the President's health care law and what they did to HSAs, and could you just summarize for us quickly?
The ACA severely cut back the amount of contributions that can be made and made other limitations. And obviously the Cadillac tax further penalizes these, as the health benefits consulting industry knows. The easiest thing to lop off if you're faced with that is an HSA.
Yeah, and didn't it require that you have to have a prescription now if you want an over-the-counter prescription to use one of those accounts? Limiting these types of structures or accounts, as Obamacare does nothing to help keep health care costs down. If more Americans were empowered to manage their own health care decisions and had more skin in the game when it came to their health care cost decisions, then what would you predict the impact to be on our health care spending, Mr. Roy?
I'm sorry. Well, let me just say quickly that the added complications will only make it more difficult for consumers to operate in the way that we would like them to do, which is efficiently.
It would reduce costs and increase choice and increase quality and increase patient service, customer service. Customer service is lacking so much in our healthcare sector because the patients don't control the dollars. The government does, the insurance companies, the employer does. So everyone orients and caters to them, not to the patient.
Thank
you. So one of the things that's important I want to mention, because it's been raised a number of times by one of my colleagues here, is this idea that consumers are incapable of making healthcare choices, that if you're unconscious because you've had a stroke, well, you can't choose your hospital. That's true. That's the proper role of health insurers, to negotiate those prices and those networks on your behalf. But there is an enormous ecosystem of healthcare choices that we can make on our own. The choice to which eye doctor you go to, who you get your primary care from, whether to get knee surgery in your state or a neighboring state from a low-price center or higher quality center. There are an enormous range of choices that can be opened up to patients to make for themselves, and there can be no doubt that they will make those choices better than the government or their employer. There was a study done last year that showed there's enormous price variation for common procedures that all of us often use. But we have no transparency into how much those procedures cost because none of us are in control of our own health care dollars. So the more patients are in control of their own health care dollars, those prices will come down massively because providers will have to compete for patients' business instead of the other way around.
Great point. One particular limit that is in Obamacare that obviously has me concerned is the over-the-counter drugs. They were designated as qualified medical expenses by the IRS in 2002, yet Section 9003 of the Affordable Care Act mandated holders of tax-preferred accounts like FSAs and HSAs seek a doctor's prescription in order to be reimbursed for purchases of these OTCs. How does requiring a script for products the U.S. FDA has already determined safe and effective for over-the-counter use, and the IRS has determined to play a key role in healthcare delivery, improve customer choice and access to healthcare?
This was one of the least rational provisions of the ACA, to force you to go to a doctor to obtain a medication that is available over the counter. That's the kind of thing that drives up healthcare costs, and it was solely done as a revenue-raising measure to pay for the ACA's coverage expansion. That would be a great example of something that this committee could do something to reform.
Great, thank you. I yield back.
Thank you, Mr. Larson. You recognize, and after your questioning, we will go 2-to-1 to balance it out.
Thank you, Mr. Chairman, and I want to thank our witnesses here today as well. As always, these are great discussions. Reuters noted almost 6 years ago, and several other institutions follow, that there is, on average, somewhere between $700 to $800 billion annually in waste, abuse, fraud, and a system, as it currently existed, that is not capable of lowering costs. Today's discussion seems to have been a little bit all over the place, but nonetheless, as a number of my colleagues have pointed out, I hope as a committee we can get beyond this notion of, okay, for the 63rd time, we're going to repeal the Affordable Care Act. It's been 6 years, and the act isn't going to be repealed. And as many on our side have said, it needs to be improved. There are many on our side that would have preferred a single-payer act that, as Mike Thompson pointed out in the military, he got pretty good service with that. And very efficient service, I might add, as well. But because of the advance of technology and science and innovation and all the things that entrepreneurialism can bring, you would think that we would even be able to do better because we're Americans. And yet what happens is, rather than us sitting down collectively and coming up with a program and a system that's better, for 6 years we've heard we're going to repeal it, instead of, okay, you guys, we're going to sit down with you on that plan that Mitt Romney submitted in Massachusetts that you then submitted that we called Obamacare. We're going to work together to make sure that we produce the most efficient outcomes on behalf of patients and people. Those people can't have individual responsibility if they're sunk at the bottom and have no means or capability or accessibility to do so. But collectively, just like we did when David Camp said, let's get together and work, let's go into the subcommittees that require us to examine what aspects of healthcare we can do to help the patient out. I note that companies like the Aetna, Mark Bartolini may be one of the most progressive and interesting entrepreneurs in the country, talking about patient-centric care and making sure they meet the patient at the household and making sure they're doing everything for the patient there to avoid stays in the hospital that cost money, to care for the patient at that level, and to do so that will combine both the best of all public health has to offer, meaning governmental public health and common sense solutions, along with entrepreneurial science and technology. I hope, Mr. Chairman, that that's ultimately what we can get to. This is nonsense. It's why the public hates us. We're having a light beer discussion here. Tastes great, less filling. Repeal Obamacare. No, Obamacare's done a lot for people. The public says, a pox on all your houses. Fix the problem for us. Today, frankly, you have a solution. I was happy to see Mr. Becerra say and see Mr. Price join, and that the bill will be submitted, that people will be able to take out. At least that's a start. This nonsense, this ongoing thing that we're going to repeal Obamacare for the 63rd time drives people crazy. They're concerned about their health and their well-being and want to make sure that it's there for them. And frankly, Mr. Chairman, I hope we can quickly get to a position where the capable people on this committee can sit down with one another and come up with solutions. You want to know why the general public is so upset with us? It's because we don't do a thing. 6 years, you don't like Obamacare, fine. What's the solution? The solution resides within this room and with the American people. Let's sit down and get it done instead of this light beer commercial that we're having.
Thank you. Mr. Paulson, you're recognized.
Thank you, Mr. Chairman, and I also want to thank our witnesses for being here this morning. I actually want to just focus some of my time actually on some of the reforms that are needed, particularly around the patient centered ideas. We've heard some other comments already about lowering costs, and I want to address some inaccuracies that were mentioned by some of my colleagues, Mr. Levin and Mr. McDermott, regarding healthcare savings accounts, and that only wealthy people use these accounts. It's important to note that according to IRS data, the IRS, only 20% of HSA account holders, they have family incomes below $50,000. So these are, below $50,000 incomes. And 83% of HSA account holders, they live in neighborhoods with median incomes below $75,000. 83% of those account holders. And only 2% of account holders actually even spend or contribute up to the amount of the maximum amount you can contribute to an HSA, which is like $6,550 for a family. And clearly if wealthy people were taking advantage of it or using it, why wouldn't they contribute up to the maximum amount if it was some tax shelter? And finally, just to mention, 24% of Americans, this is like a quarter of the population across the country, have an HSA or an HRA eligible insurance plan that they can participate in, which is actually a really, really big number. I personally think we need to go more in that direction because people appreciate the choice of flexibility when it comes to making sure that they can use health care for themselves or for their families from a consumer perspective. They want to be able to shop around for the best quality care at the lower cost, just like they can shop for anything else. And it's probably one of the reasons why there's such a high percentage of Americans now, 20 million, that are using HSAs actively. In Minnesota, we have a population just over 5 million people, but 800,000 people have opted now for some health savings account eligible health plan, which is a big number. And I just really believe, and I think we're hearing some more conversation on some of your testimony today as well, that these HSAs should be a central component of health care, that these accounts give more people more choice on how to use their health care dollars, control over the care that they receive, and ultimately, they're going to be smarter consumers. And I'll just say also, I've introduced legislation, the Health Savings Act, with Senator Hatch in the Senate, that will expand the use of these HSAs and make sure that people are able to lower their costs. The bill would allow more people to access these accounts, including seniors who are in Medicare, active military personnel, and active military members of the military, Native Americans who are enrolled in Indian Health Services, and members of healthcare sharing ministries. And I'll just say right off the bat, after I introduce the bill, positive comments are coming in from some of my constituents. I hear from Aaron, who said, "This is a great idea. I love my HSA as it makes me into a healthcare consumer." Robert put out, I think he put on Facebook, he said, "Thanks for taking this common sense step to help defray our healthcare expenses." And then finally, Ed responded and saying, "Why aren't these available for seniors already?" And so I think this is moving in a positive direction. And we also, with the bill, will make sure that we are going to be expanding what the accounts can be used for, as Ms. Jenkins had mentioned, for instance, but we'll be able to include preventative care prescription drugs, health insurance premiums will be included, over-the-counter medications without that doctor's prescription, physical fitness programs, so wellness, nutritional supplements, and membership fees for innovative direct primary care models. So clearly, these accounts can be a key solution for everyone who is dealing with higher health care costs. And, Mr. Roy and Mr. Antos, I know you've written a little bit about this as well. You've talked about it. Anything else you want to just share about the importance of these accounts and how we should make this a highlight of the reforms where we're trying to go?
You've made a lot of great points, Mr. Paulson. One I would emphasize in what you alluded to is that health savings accounts have the potential to transform health coverage for the poor. Imagine if we took the cost-sharing subsidies that are in the ACA and converted those into health savings account deposits. That means if you're sick, you can use that HSA deposit to pay off your deductible. But if you're healthy and you stay out of the hospital, that HSA can accumulate and roll over and generate compound interest. And over time, that person who today is low income with negative net worth can actually have a positive net worth, pass that nest egg off to their children. And you actually can transform the entire economic trajectory of that family and future generations of that family. So that is the power of health savings accounts. They can do more for poor people than any other approach to health reform.
Good. Mr. Antos, anything else to add, or final seconds?
Well, we have a long way to go.
Right.
But beyond that, yes, absolutely. A properly funded system that includes HSAs with smarter regulations so that people can actually buy the kind of coverage that they need will take us a long way.
Thank you.
Thank you, Ms. Black. You're recognized.
Thank you, Mr. Chairman, and I thank all the panels for being here today. This is a very important topic, obviously, and I think my colleague from Illinois used a great word, restlessness, that we feel restlessness by the people, and especially the people in my district, as I hear from them about health care and about the uncertainty and all the things that go along with it. So I, as a healthcare practitioner for over 45 years, being a nurse and having seen that pendulum go from here to here and now back maybe toward the middle, I just wrote down 4 things that I think are the key pieces of this. One is choice, one is access, one is portability, and the other is affordability. So I want to go through each one of those just very briefly, talk about choice, which has certainly been a topic here within the panel today. And one of the things I can tell you is that the Affordable Care Act has not helped with choice in my district. It has limited the number of insurance companies that actually participate in the Affordable Care Act. So I have constituents who tell me, I really like my doctor, I can't go to my doctor anymore, I can't go to my physical therapist, I can't go to this, that, or another. So choice has really been limited, although it's been lifted up as, you know, like the panacea that has solved everything. The affordability piece on that is folks will tell me, yes, I have a subsidy that helps me pay my premium, but you know what? I can't afford my deductible. I can't afford my copay. So do they really have insurance? No, they don't. I also know that it's driven the cost up in the private sector. People telling me now every day, and I'm not exaggerating when I tell you every day in my office we get a call or an email about how their insurance has been affected by what has happened most recently with the Affordable Care Act. So the portability piece and the access. So let me go to my question before I run out of time. Mr. Roy, I want you to answer this for me. What happens if a person currently with employer-sponsored insurance loses their job? Can they keep their plan?
Well, they can have COBRA for 18 months, but it's very difficult to transfer that coverage to individually purchased insurance. There's a gap in the transition. They don't have the ability to protect the exact plan they had before.
So that brings up a really good point, is that they have COBRA, and I have constituents who are in this situation. Let's just say that the employee does get the COBRA, but their benefit value for their plan was $3,000. That's probably even low, consider what insurance really costs today. But does that employee get to take that benefit with them while they search for a new job and take that $3,000 so that they can help pay their COBRA?
I don't believe so. I mean, I think it depends. Joe might
Mr. Anthos?
answer to that.
Yeah. I think the answer clearly is no. At least that's what I'm learning from my constituents. So you have that insurance, but it's not really portable because you can't afford the COBRA. Many people will tell me, I can't afford the COBRA. Yeah, it's there. It's a benefit for me, but I can't afford it. So we put them into a difficult situation where they had employer-sponsored insurance, but they don't really have an option there when they leave it because it's really not portable. So for all the benefits of the employer-sponsored based system, which there are many, and I'm not at all saying they're not. One great drawback is this, that if the employee loses their job, then he or she loses support for the purchase of their health care insurance. If we were to design from scratch a health insurance system, then how would you mitigate against this profound loss? Mr. Roy, you want to answer that?
Yeah, you know, one analogy that was made earlier, one comparison that was made earlier today was between auto insurance and health insurance. And I think that's a really great way to think about what health insurance should look like. We don't expect auto insurance to pay for our gasoline or oil changes or our wiper fluid. We expect it to protect us against catastrophic financial loss if our car gets totaled, it gets stolen, it gets crashed, we get into an accident. That's what health insurance should be. Health insurance should protect every American from bankruptcy due to medical bills. But the moment we expect it to dominate all of our health care choices is the moment that it becomes too expensive. And to your point, we don't ask our employer to sponsor our car insurance for us. That would be completely irrational. And similarly, it would make a lot more sense to have individuals have the ability, the option to choose their own health insurance. Now, there are arguments for employer-sponsored health insurance. It should continue because there's a certain scalability. If you have a large group with 300 employees, the ability to purchase health insurance that's more affordable for that population is greater sometimes than if you purchase it for your own. But that shouldn't just be about large employers or even small employers. That should be your church group. That should be a professional association. That should be any group of people that wants to get together to pool their risk and pool their options.
So there are other options out there which we should be speaking about. And just to conclude, if you have somebody who is on the Affordable Care Act, they really don't have a lot of choice either. And that is not portable either, because if they want to take those subsidies that they get from the federal government and purchase something outside of the system that they're required to use, they don't have that choice either. So
let me make an analogy there that, you know, the choices in the Affordable Care Act are you can buy a car from GMC or Honda or Ford or Toyota so long as it's a green pickup truck.
My time has expired. More than my time has expired. Thank you.
Yeah.
Excuse me, Mr.
Chairman.
Pascal, you're right.
Thank you, Mr. Chairman. This is the first time I've ever heard anybody testify and compare one's health to one's automobile. And I'd just like to know, perhaps, when we get to that point, which should not be covered in terms of your own health. I think we'll have some debate over that. That is exactly what got us into trouble from the very beginning. The fact is, sir, that we cooperated after Plan D was defeated, the very prescription drugs you're talking about here. We cooperated, even those of us, myself included, who voted no against that plan. We voted. We sat down and worked out. And then finally, when we got ACA, we changed the law so that we wouldn't have that gap where people were paying premiums and not getting any benefits. We can do this. So this is about myth. I take Mr. Larson, my brother here, you know, he talked about light beer. This is the age of mythology. There's no two ways about it. Yesterday, we had the mythology of blaming the IRS for everything except the weather. And then when we found out who are the people we can most rely upon in government, and we looked at the Treasury Department had the lowest tax delinquency rate in the federal government, and guess where we were? We guys and gals. They're 1.2%, and we're 5.1%, and the general public is 8%. This is about myth. That's what it is about. And we're going to dispel that myth between now and November. Let's make it clear. We're not going to be the foolish folks that ran away from this after they voted for it in 2010. Those days are over. They are gone. A conversation, if it produces a plan at all, that is centered around ideas that we know will not provide the same level of consumer protections that the ACA will do, will not result in as many people getting coverage, and will not help balance risk pools. We haven't even talked about that today, have we? And which is key to keeping premiums down, is what we should be about discussing rather than trying to tear down what is the law. 63 times. How many times can we do this? Obviously, maybe 100. There's no cap. Let me ask this to you, Mr. Kreisberg. We have yet to hear about a concrete alternative. By the way, we not only do not have an alternative plan, we don't have what we're going to do in the transition period when we tell the 20 million new people who have insurance, wait, because the new plan is on the way. It's in the mail. So this alternative, one of the favorite centerpieces when talking about the alternative to the ACA is that they would allow people to buy insurance across state lines. Every state has a different insurance commissioner. Every state has different insurance lines. You hear these presidential candidates talk, why can't we go across the state? If they should know the facts, unless they're talking without them knowing what the system is. It's like immigration. If you don't know what the system is now, how can you criticize it and say, let's have reform? Allow people to buy insurance across state lines. That's the fix. Generally without any regulatory role for the federal government. Would a policy like that, what kind of impact would that have on the consumer, sir?
Well, it would have virtually no effect on rates. I think there's been a number of studies that, since the Affordable Care Act has been adopted, we have essential minimum benefits across state lines now from the federal government. There are a number of state benefit mandates which those states are entitled to enforce within their own states, and we've always supported that. We've always opposed interstate sales because we think it's a violation of states' rights in this particular regard. So we don't think it has, right now, much of an impact on rates. We think it's adverse to consumers. I think you lose regulatory oversight You may have some difficulties with reserve requirements that insurance companies are allowed to hold. And ultimately, I don't think it serves any productive purpose at this time.
One final question. The last myth we have time for today, and that is it's a job killer. Now, I've seen data from different universities, Labor Department. I can't find that. Would you help me?
Sir, it is not a job killer.
Well, then spell it out.
As I indicated before, even CBO has said that it's really a matter of labor supply. People may now have the ability to get insurance outside of their workplace and withdraw voluntarily from the labor market as opposed to employers laying off employees because of the Affordable Care Act.
Thank you. Yield back.
Thank you. Mr. Kelly, you're recognized.
Thank you, Chairman. What I'm going to start off with is the actual purpose of the hearing. And so the purpose of this hearing is to learn about the different health care tax expenditures in the tax code and determine those in need of reform. And I think that so often everything gets lost in the translation. So when we talk about tax expenditures, what we're talking about is the government giving up anticipated revenue to subsidize. And in an awful lot of what we do, each of you is here today representing a certain agency. You are all either 501c3s or 501c5s, right? Those are nonprofit organizations. By definition, in the tax code, you pay no taxes. Each of you, for the organizations that you work for, have health care supplied by the people who you work for. You do not have to pay for it. The question today was about who pays for this, because we talked, I think initially, and I may be wrong on this, Chairman, 150 million people are covered by employee-sponsored insurance. Part of, I think, the Patient Protection and Affordable Care Act is how are you going to pay for it, because we always worry about how are you going to pay for it. So if you subtract, if let's say all of a sudden employers said, we're just not going to do it anymore, you'd lose 150 million who are paying for their own insurance to begin with, right? Now, is it true that we're talking about a loss of revenue, tax revenue? Here, this is what we're talking about, all the different tax codes right now, right? This is money that won't be garnered by the federal government. And so we're saying that in some cases we have to subsidize those plans for people who can't pay for them. I just want to read to you. A subsidy is a sum of money granted by the government or a public body to assist an industry or business so that the price of a commodity or service may remain low or competitive. My question to each of you, who supplies the money for the subsidy?
In both cases, it's the worker, right? So you Mr. Kelly, you had said that.
I'm with you. It's okay.
That I don't.
Mr. Kreisberg, I'll come back to you, Mr. Roy. I'll come back to you. I understand. But who pays for the subsidy?
If you're talking about
I'm talking about subsidies.
The advanced premium tax credit on the Affordable Care Act.
I'm talking about where does the revenue for the subsidy come from?
It comes from the taxpayers.
Taxpayers.
Right, from the taxpayers.
It's all generated by hardworking American taxpayers. It's not generated by the government. The government looks at every single dollar we make and says, here, we're going to allow you to keep a fractional part of what you earned. The government says to every hardworking American taxpayer, we are going to allow you a portion of each dollar that you earned. The government will take from taxpayers the amount of money they need to run programs and say, we will use it better because we know how to use it better, but you will supply it. Am I wrong on that?
No.
Okay.
And one thing about the employer tax exclusion that is.
Listen, I'm running out of time, Mr. Roy, and I don't want to give a lecture, but I want to get down. The purpose of this meeting was to talk about tax expenditures and capping what an employer is allowed to deduct. I happen to be in a private business. I have always provided health care for my people. Now I'm being told that you're not going to be able to deduct that as a cost of doing business because you've actually gained that in order to avoid paying taxes. And the people, and by the way, the people that receive that benefit, they should be taxed on that because that was actually revenue. We're trying to adopt some source of revenue from hardworking American taxpayers. Again, all of this stuff is being driven by taxes.
It's not to raise taxes. It's actually to lower taxes.
Mr. Roy?
Increased out-of-pocket.
Mr. Roy, do you pay tax on your health care plan?
Yes, I do.
Do you really?
Absolutely.
Okay, it's provided by the agency you work for.
We all pay taxes.
You pay wage taxes.
Our taxes pay for the cost of our health care system.
Okay, I get that part. I get that part. Listen, I understand that world. I get that part. The reality of it is it comes from people who go to work and earn income in companies that are profitable. That's where the taxes come from. And the other part of it is we get it from printing money or borrowing money, which, by the way, we have every single taxpayer sign on. They are co-signers on that debt. But the purpose today was to talk about different health care expenditures, and I'm just saying, I'm submitting to you that we are forgetting the most important part of this, and that is the people that provide the revenue. There's nobody here that says they don't want health care for people. The question is, how do you pay for it? And at the end of the day, it's going to be by Americans. They're going to pay for it. Some, for some that can afford their own, some can't. I get that whole part of it. But we are going to change the tax code in order to collect more revenue. And when the government says they're losing revenue, what they are actually saying is, Mr. and Mrs. Taxpayer, you're going to get to keep more of your own money. It's going to stay in your pocket. You can decide how to spend it. That's what it's about. It's about a loss of tax revenue. That's all this meeting is about. All the rest of it is political talking points or election year talking points. It's not about the issue, which we've all been addressing, and that is, how do we pay for this? And the answer is, every hard-working American taxpayer is going to contribute to it. My question, and it always comes down to the same thing, I love the fact that as an employer, I've been able to do things for the people that I work with. But I don't think I should be held, you're only using that as a tax, then the people you give it to should be taxed for it. We're looking at a cap on what employers are allowed to deduct as a cost of doing business. I would submit to you there's a heck of a lot more to running a business.
All time has expired.
Thank you, and I yield back.
Mr. Renacci, you're recognized.
Thank you. Thank you, Mr. Chairman. I want to thank the witnesses for being here. It's interesting. I said this yesterday. American people, if they watch this, they would get very frustrated. And as my friend Mr. Larson said, they get frustrated, but it's not because we're talking about they get frustrated because we're talking at each other instead of listening. And that's the problem. We need to listen to our witnesses. We need to listen to the people we represent. So I'm going to go back. Employers, I'm glad that Mr. Kelly got us back on track as to what the hearing was about. You know, employers cover, this per the CBO, 63% of health care through employer-sponsored plan. You guys would agree with that, right?
The worker is paying for that because it's part of the worker's overall compensation.
I understand.
Employers,
but employers are covering.
Part of when an employer hires someone, the cost of their overall compensation is
We're going to get to that.
calculated.
We're going to get to that. So employers, in fact, cover 155 million people through employer-sponsored health care. I think, Mr. Antos, you said yes to that. So I go back in the district and I talk to my employers. I talk to my employers too. You know what my employees say? They say, I don't want the responsibility of trying to find my own health care. It's complicated. I like the idea of an employer covering my health insurance. And by the way, I've hired many employees, and you know what they say? I want a good wage. And you hire them for a good wage, and then you give them health insurance. So the health insurance doesn't stop me from paying them a good wage. You guys are saying that, you know, it's reducing. They don't come in there saying, you know, I'm only going to work for this and you should pay me more because of health insurance. Most of them love that we're covering health insurance. So they say to me, when I talk to the employees, we don't want to be burdened with trying to select. We like the idea of the employer doing this. We like the idea of the employer covering everything. We like the idea of being part of a bigger plan because I can't do it on my own. That's the other thing they say. Then I go to the employers and I ask them, and you know what they say to me? Congressman, that big wet blanket the government keeps throwing on top of us, you're raising our costs for health insurance. You're raising our costs, which is shown for the last couple of years with the Affordable Care Act and other ways. And now you want to cap it and cut it at the top. You want to hurt us again. It's not fair to the employer. It's not fair to the employee. We have to go back to what the basis is. If we went to those 63% and asked them, are they happy they're covered with health insurance? They would say, that, I bet you they are happy they're covered with health insurance. So here's my concern. We know health care costs are going up. We want to capitate it and say, Mr. Employer, you can't pay it. You can pay it, but anything above that, it's going to be a tax increase to you because we're not going to have it as a deduction. That's a problem. No. So the only way, in my estimation, and this is what drives me crazy, and now I'll come to you, Mr. Roy, you keep saying an employer-sponsored plan doesn't give the employee choice. But I would ask you this. Aren't there employer-sponsored plans that give and could give employees a choice over their health care decisions if structured properly?
So there's a couple of points to make in response to that. The first is that
I don't have a lot of time,
nobody's talking about tax increases. People are talking about letting patients control those dollars themselves, increasing their take-home pay.
I know that, but
letting
let's
them
get back to it.
decide what they want to fund. On the issue of choice for health insurance plans,
If the plan is structured properly.
employers can decide whether to offer one plan or two plans or three plans, but shouldn't workers have the choice to choose between their employer-sponsored plan and 100 different plans that are out there independent of their employer?
They can
if
do that
want
right
to?
now. They can do that right now.
It's
If they-
much harder for them to do that because the inequities in the tax code make that much more
They
expensive.
can do that right now, but I guarantee if you talk to the employees, see, this is what happens. The American people get frustrated with us in Congress because they want us to listen to them. They don't want to make those decisions. They like the idea of selecting a plan that their employer gives them. And they definitely don't want to have somebody come to us and say, this is what we think's best for you. They know what's best for them. They want us to represent them. That's what's so frustrating. But that's what's great about these hearings, because I do like to hear some of your thoughts, and I've listened. The next question I have, Mr. Antos, will more people lose their employer-sponsored plan if we cap the employer exclusion?
More people will move off of employer-sponsored plan. But let me clarify something
Wait a
that
minute, will they
both you
lose-
and Mr. Kelly said that I believe is incorrect, which is that I don't think anybody's proposing that the employer's ability to take off their top line legitimate cost of doing business, which includes their contributions to all forms of compensation for employees. Nobody's talking about capping that or eliminating that in any way. So what we're talking about is limiting what the employee can essentially exclude from his income taxes, but it's not going to affect the employer.
That's even worse. Now you're going to add taxes to the employee. Again, if the American people hear what you just said, they're going to be really upset. I yield.
Time has expired. Mr. Davis, you're recognized.
Thank you very much, Mr. Chairman, and I too want to thank all of our witnesses. Newsweek has an article written March 3rd titled, "How Obamacare May Lower the Prison Population More Than Any Reform in a Generation." It was written by Elijah Wolfson. Tony Preckwinkle, who is president of the Cook County government, second largest county in the country, with one of the largest jails in the country, responded to that article by writing a letter to the editor. And here's what President Preckwinkle wrote. She said, "I commend Newsweek for recognizing the vital connection between Obamacare and safer communities." She went on to say that in November 2012, Cook County was granted a Medicaid waiver that has already allowed us to provide health insurance to over 86,000 low-income residents, including 2,600 formerly detained individuals. Mr. Chairman, I would ask that both these articles be inserted into the record.
Without objection.
Since we've not seen any alternative to what is often called Obamacare, except a national health plan, preferably single payer, let me mention a few of the accomplishments and benefits our country has experienced from the Affordable Care Act. 20 million people have gained health insurance coverage who didn't have it. The gains since 2013 have been the fastest and most rapid since the decade following the creation of Medicare and Medicaid. The uninsured rate is below 10% for the first time in the history of this country. The uninsured rate among young adults ages 19 to 25 has fallen by 52% through the third quarter of 2015. We know that states that expanded their Medicaid programs have seen rapid gains in health insurance, much more than those states that have not. Millions more workers are now protected against unlimited out-of-pocket spending. Since the Affordable Care Act became law, health care prices have risen at the lowest rate in 50 years. Hospital readmission rates have fallen sharply since the passage of Obamacare. The private sector has added jobs every month since the Affordable Care Act became law. Thanks to the Affordable Care Act, an estimated 20 million people have gained health insurance, and for the first time in history, 9 of 10 Americans have health insurance. Among African Americans, adults, the insured rate declined by 53%. Among Latino adults, the uninsured rate dropped by 27%. The gains for women have been rapid, and among young adults has dropped 47%. It prohibits coverage denials and reduced benefits and protects 129 million people who have some type of pre-existing health condition. More than 1 million Illinois residents have obtained health insurance coverage. And on March 22nd of this year, the Department of Health and Human Services announced that Medicare spent $473.1 billion less on personal health care expenditures between 2009 and 2014 than previous spending trends would have indicated. Mr. Kreisberg, let me ask you, have you heard of, seen anything, or know of anything that would do a better job of meeting the health needs of our country than that?
I don't think there's anything in the current dialogue today, given the, where the American people are, that would do a better job than what the Affordable Care Act has done in terms of expanding coverage. As I said earlier, I don't think we've met the full potential, and I think we do need to work on fully implementing the Medicare expansion provisions of the Act so we can bring some of the benefits that you've described to more people.
Thank you. Mr. Mean, you're recognized.
Thank you, Mr. Chairman, and I appreciate the panelists here today. I wish I had a chance to actually answer questions instead of being lectured to, but because I guess this is a hearing. But in any event, look, I thank you for your work, and I know one thing. When I go back in my district and I talk to my employers, Obamacare's not working to them, and the frustration level is the highest I've ever seen. 8% costs per year in increase, but I also have questions about how we work this system to try to, so I'm going to ask 4 things, if you can address them as best you can. How do we start, if we're going to do some sort of a cap, and it's designed to make it more available to everyday people, not just to the benefit of the more wealthy members in that. So if we try to create caps, how do we keep the young, healthy employees inside that system? My second question is, if we're going to create a tax system that does some kind of a refundable tax credit, how do you deal with people who are families that don't currently have access to employer-sponsored programs? And what do you do with those who have an income level below, the 300%? A third question that my colleague talked to, how do you make consumers understand what to buy when they have a doctor tell them they're sick? First, they're sick. Hard time to make a lot of choices. Second, you don't understand what you're buying. You're being told, you gotta get this test. And then the last question, I'm throwing a lot at you if you have it. I'm anxious to hear us make, but how do you know an employer isn't going to keep the savings themselves and not pass it on in the form of wages that'll increase? A lot of questions, but if you can help me.
Those are all great questions. I think you've asked the right questions. So on the issue of whether the employer will keep the money or raise wages, the economic literature is overwhelming in indicating that there is an exact one-to-one correlation between, because it's overall compensation the employer thinks about, and it's a competitive market, right? If you want to retain those workers and not lose them to a competing firm, you got to pay them what the market's paying them. And so if healthcare costs go down, the cost of insuring your workers goes down, that gets returned to workers in the form of higher wages. Okay. So we can be optimistic about that. On the question of patient choice and how if you go to the doctor, you don't actually know, the doctor says you're sick, how do you deal with that? It's a classic problem in healthcare. There's a flip side to that, which is a lot of times you as a patient know a lot more about why you're sick and your family history and your background that the doctor does, who's just glancing at your chart, has forgotten a few things, your medical records are all over the place. So there's asymmetry in both directions. And the more the consumer's in charge of his own healthcare dollars, the more that doctor has an incentive to be really responsive to that patient and that patient's needs and that patient's unique medical history. And that's what our current system works against. And so, if I've missed anything that you've addressed, please.
Well, no, I asked two other questions. I want to know about young, healthy employees. How do you keep them in if we cap this system?
Right. So the issue of whether the young, healthy employees will withdraw from employer-based care and go off shop on their own, you could see that to some degree, but you could also see a lot of people stay. And the reason why they would stay in the employer-based system is because of the economies of scale that come from a large employer or even a smaller employer purchasing health insurance in bulk for a group of its employees and having that negotiating power that comes with that versus being an individual shopping for coverage. So I think employers should retain some confidence that they have a lot to offer to that employee and they can provide other incentives to say, hey, we want you to stay in our risk pool. Here are some other things that we can offer you that if you bought insurance on your own, maybe you wouldn't get as good of a deal.
Okay, I wish we had time for follow-up questions, but I wanted to get my fundamental questions answered. And the last one was, how about a refundable tax credit for somebody that's not in an employment situation?
That's essential. So if you only have a non-refundable tax credit, then for people who don't have income tax liabilities, they can't get the financial assistance they need. So refundable tax credits are a very important part of equalizing the tax treatment of health care.
Mr. Antos, you got any response? Any thoughts on any of those issues?
Yeah, well, one other aspect has to do not just with wages, but also with people being able to keep their jobs. There are many margins of adjustment that employers face, and by giving more flexibility to the system, we'll not only have people with higher wages, but in some cases, when there's loose labor markets, when the labor markets are not doing well, the people will less likely to be laid off.
Thank you. Appreciate that.
Thank you. Mr. Holding, you recognize.
Thank you. Mr. Roy, in your testimony, you stated that reform should give workers more choice to purchase the kind of health coverage that is affordable for them and their families. But, unfortunately, many of the new requirements of Obamacare have made employer-sponsored coverage increasingly unaffordable with higher deductibles, premiums, and cost sharing. And employees are also presented with fewer choices, as we've discussed, when it comes to employer coverage. So rather than dictating exactly what benefits must be offered, would it make more sense to allow employers to provide a defined contribution to their employees so that they can shop around and find the products that meet their needs a little bit better?
Absolutely. That would be a tremendous innovation in the delivery of health insurance in the employer market. You have a defined contribution that they can then say, look, if that, let's say it's $5,000. If I want to spend $6,000, then I can do that with my additional funds. If I like the $5,000 health insurance plan, let me buy whatever we want. There's an intermediate a way of getting there, which is private health insurance exchange that some large employers like Walgreens are using to say, we're going to give you this much money, buy whatever health insurance among these 10 plans that are on the exchange. There are a number of people working on improving that modality for delivering health coverage to the employer market.
Well, defined contributions are pretty common practice in the world of pensions.
Yes.
But not health benefits. So is there something in the tax code or federal law that treats defined contributions differently than defined benefit plans?
Yes, unfortunately, if you just give them the money to buy whatever health insurance they want, it doesn't qualify for the employer tax exclusion, except in these private exchange contexts where you can convert it in a certain way. With the self-insured population, you have a little bit more flexibility than through the conventional employer tax exclusion.
So do you think that treating defined contributions in the same way we do defined benefits under the tax code would help to make the health care cost more manageable and predictable for employers? And similarly, do you think it would give employees more flexibility in their insurance coverage?
Absolutely, and there's been a lot of concern expressed today about if you reform the employer tax exclusion, would that disrupt coverage in the employer market for those who prefer it? And one of the best ways to ensure that employer-based health coverage continues to be robust is to give employers exactly the option that you're describing. To say, you know what, we're going to get out of the business of picking the health insurance plan for you, but we're going to be allowed to have a defined contribution, which then you can use to shop for coverage you want. Because that's a benefit that employees would love to have and would be loath to give up.
Now, importantly, on the flip side, do you think this would create incentives for insurers to compete for this business, correct?
Absolutely.
And competition ultimately would drive costs down because your insurers are competing, correct?
It would drive costs down, and it would also improve quality and customer service because, again, insurers would have to compete for your business.
Thank you. Mr. Chairman, I yield back.
Thank you, Mr. Doles. You're recognized.
Thank you, Mr. Chairman, and I want to thank our witnesses again for your time. And I too, join my colleague, Mr. Meehan, in hoping that this could have been more question and answer to hear from you, as opposed to taking the short period of time for really more for speaking at you. I will kind of try to get to some questions, but I will tell you, as a small business owner, the frustration level that is out there, not only amongst the employers, but amongst those looking and seeking to provide insurance for their families, is extremely high. They are frustrated, largely because as an employer, and I'm a small employer, we see our premiums, and have seen traditionally year after year, even before the Affordable Care Act, they would rise up pretty significantly, times 44% a year. And yet, certainly as someone that runs a multi-generational business, we consider the people that we work with part of our family. And honestly, that's where that trust comes in, because many, especially in these small businesses that are out there, they trust the people that they've been working with for 10, 15, 20 years and trying to provide or make the choices that they believe would be best. As we look at the flexibility, which I think is absolutely critical, I think we're also getting away from the idea that what our goal should be is that we want quality care for everyone. And we want to make it as affordable as possible. And what we've seen more recently is we've seen premiums go through the roof. Deductibles have gone sky high. And so for a family of four, it would not be uncommon for them to pay $2,500 a month in premiums and have a deductible of $12,000 plus. So for that family of four, they're paying 20 some odd $1,000 of insurance before they get $1 of coverage. And we've done a masterful job of actually disguising the costs of health care. Right? How much does it cost to go to the pediatrician? Well, I'll tell you that, well, some people say it's just $20. No, that's the copay. And so really what we've done is we've taken consumers completely out of the equation. And what we really need to be focused on is how do we enable that competition, Mr. Roy, that you were just talking about? And the other thing that I would argue we'd like to do is have the flexibility for employees not to feel trapped into a job. Because if I leave, I'm going to lose my health coverage, and therefore I potentially might not be able to have that coverage as I move forward for my family. And really terrifying, obviously, for those that have family members that have great need. I'm reminded of a study that was done up in Wisconsin. Hospital A had a knee replacement. It was $57,000 for the knee replacement. Hospital B, 3 miles down the road, so it wasn't far, and still basically right there in the neighborhood, was $38,000. Now, we associate better care with $57,000, and yet what was amazing was better outcomes actually happened at the hospital for $38,000. And my point is, shouldn't we know that? Shouldn't we be able to get that data out there and drive more people to the hospital that's doing it for $38,000? Mr. Antos, what happens to the hospital that's doing it for $57,000?
They're making a lot more money.
Well, but what happens to them if we are able to figure out that the hospital 3 miles down the road is doing it for?
Well, if there is actually usable consumer information about their cost and the quality of the services, what's going to happen is that it's going to drive the expensive hospital to revamp the way it does its business. It's going to drive the hospital to talk to their doctors about how do you manage care.
Ultimately, what we're trying to focus on in this hearing is what can we be doing with regard to our tax code to make better decisions. And frankly, we don't want to talk about an increased tax on hardworking taxpayers. And frankly, we want to encourage those employers to be able to continue to do it. Because I would argue as a small business person, We want to make sure that we're able to attract and retain good people. But I do believe that we have to come up with a mechanism that provides that flexibility for employees, for those hardworking taxpayers, to say, I've got good quality care, regardless of where they're working and regardless of, and for those even that are not working. And that's where I think that refundable tax credit really has to come into play. Can you talk to us about what we can really be doing in terms of focusing on that flexibility so we don't have the job lock, as it were? Mr. Roy?
Yeah, so as both of us described in our prepared remarks, if you gradually cap the tax exclusion in a way that's revenue neutral, so it would involve no tax increase on any worker relative to what a current law is, you give people that flexibility to opt out if they want to and shop for coverage on their own. And also, if they change jobs, they own their own health insurance plan, just like with auto insurance. Your auto insurance doesn't change when you switch jobs. It's your auto insurance, your life insurance, et cetera. Same with health insurance. It should work the same way. You should be able to transition. You should be able to continue your coverage, and it shouldn't have to be sponsored by the employer to do that. And one mechanism to do that and integrate it into the employer-based system is what we were talking about just a minute ago, which is to have a defined contribution at the employer level, which then the individual can take and use to buy the insurance and keep the coverage as he changes jobs.
I'd love to hear other responses, but my time's expired, Mr. Chairman.
Thank you, Mr. Dole. Mr. Rangel, you're recognized.
Thank you, Mr. Chairman, and let me thank the panel for your patience and indulgence in coming here to share with us. Mr. Roy, facetiously, Dr. Price and I said we will adopt your policy, but I would be serious to find out, is it at all possible for you to present the plan that you had to us for us to look at, and how soon could we get it?
I would be happy to do it at any time that's convenient to you and your office, Mr. Rangel, at any time that's anyone in the committee or anyone in the Congress.
Would you send it to us directly, and then I would arrange with Dr. Price and others to be able to discuss it, because it pains me to have struggled so long for expansion of health care to find people that would be anxious to repeal it and not to have a plan to suggest how the vacuum will be filled.
Absolutely, and you know what I would say, Mr. Rangel, is that I've reached out many times to Democrats, both in the House and the Senate.
You don't have to reach out any further.
It's sometimes very difficult.
You also are a journalist, right?
Say that again?
You are a journalist as
yes.
well as you can prepare the press release now that I have said that I am anxious to see what's on your mind, because with all of the activity on the floor to repeal the Affordable Care Act, I haven't seen an alternative, and you are prepared to show that to me. Now, you're not a health care provider, are you?
No, I'm.
But you are considered an expert in delivery of health care, aren't you?
Well, I will defer to this committee that invited me here as to whether we have expertise or not.
You have provided this advice to Governor Mitt Romney, haven't you?
I was an advisor to Mitt Romney in the past, yes.
And as well as Rubio, you
yes.
advised him, and Nick Perry.
Yes, sir.
And so, in addition to an expert in healthcare, you also could be considered a political analyst in terms of providing political advice as relates to healthcare. Is that true?
I provide policy advice, not political advice.
But you have given a lot of policy advice to outstanding Republican politicians, right?
I'm happy to give policy advice to anyone who asks, and it's mostly Republicans who ask.
I know you would. You do get paid for giving advice, don't you?
No, I was a volunteer on...
have you ever been paid to give an advice?
Have I ever been paid to give policy advice?
Policy advice as relates to health care.
Well, I'm an employee of the Manhattan Institute, so I'm
okay.
in that
Well,
capacity to do research
so
on
what I'm saying
policy.
is, of course, you would welcome giving advice to. No Democrat have accepted your services.
But I would be eager to provide them.
Now, you mentioned, what group did you mention? The Financial Institute? Are you with them now?
The Manhattan Institute for Policy Research. That's the nonprofit think tank. Yes, I am a senior fellow at the Manhattan Institute.
Did you ever work for J.P. Morgan?
I did many years ago, yes, before I started working in healthcare policy.
And when you went to work for healthy policy, did you form or become partner in a firm called Torreya Funds?
No, I was not a partner in Torreya.
Were you a part of Torreya?
I was an outside consultant. I worked with some of their individuals.
So you gave advice to Torreya?
I was a consultant, yes.
Does consultant mean giving advice to them?
Sometimes, yes.
And is Torreya a hedge fund organization?
No.
Do they advise a hedge fund organization?
No, they mostly advise companies, such as biotechnology companies that are trying to develop new therapies.
Have you given advice? Have you been described as a advisor to hedge fund investors?
Yes, I've sometimes given advice to investors, as I give advice to policymakers and other people.
But since your specialty is in healthcare, would you have concentrated in giving investment advice or policy advice to hedge funds that are concerned with the providing health care? That's where your expertise is.
I'm not sure if I understand the question. If the question
I'm trying to connect you with hedge fund providers. That's what I'm trying to do.
That's become clear, Mr. Rangel.
And so I don't know what it is. What part of my question is it that you don't understand?
So
I want to see where you get your money. Hold it. You're not a doctor. You're not a health provider. Please, just 1 minute.
Sorry.
You're not a doctor. You see, you took my time away, but perhaps the chair might afford you some time to separate yourself from hedge fund investors as relates to health care.
My policy advice is entirely independent of my previous career as an investor in the healthcare system.
Thank you. Mr. Roy is an acknowledged expert, incredible witness on healthcare reform. We welcome your attendance today. Mr. Rice, you're recognized.
Mr. Kreisberg, you work for a big public sector labor union, correct?
Yes, sir.
And you do design work and consulting, I guess, for their health plans?
For the staff health plan?
For whatever health plan that they have.
I have collectively bargained health plans covering hundreds of thousands of workers.
How many of those workers are covered under the Obamacare exchanges?
I'm sorry, I'm having a little trouble.
How many of those workers are covered under the Obamacare exchanges?
The ones that I negotiated for are not in the exchanges, but other members of ours are in the exchanges.
What percentage would you say?
Of our members are
Yeah.
in the exchanges?
Yeah.
I would probably say 5%, if that high. We have more on, we do have more in the Medicaid expanded coverage program.
Do you think if you moved all of your members to the exchanges that would increase their satisfaction with their health care coverage or decrease it?
I believe it would decrease their satisfaction.
The Cadillac tax but you know, you're sitting here saying that you like the Affordable Care Act and but you don't want your members on it.
That's not what I said.
Okay, well, explain it to me then.
Well, for many of the people who are covered in the healthcare exchanges, they had coverage in the individual market, which was not working well at all, or they had no coverage at all. So we believe the Affordable Care Act healthcare exchanges are very positive things for those members. But we're a firm believer in the traditional employer-sponsored insurance, of which our members are fortunate enough to normally be able to access.
Jonathan Gruber testified that, you know, when he was helping design the Affordable Care Act, that the Cadillac tax was specifically designed to increase the cost of employer-provided insurance over years and thus force everybody into the exchanges. And what I'm asking you is, if the Cadillac tax works as Mr. Gruber designed it and forces all the employer-provided health insurance becomes so expensive that people can't do it, and all your members are transferred onto the exchanges, are they going to be happy with that, or are they going to be disappointed?
Well, first of all, I think Gruber's wrong.
Well, he designed the plan.
There's some controversy over that. But he's wrong in terms of what would happen. What would happen, in our view, excuse me.
Mr. Roy, is Gruber wrong or is he right?
Gruber wrong about what specifically?
That the Cadillac tax was designed to make employer-provided health insurance more and more expensive so that people would eventually be forced onto the exchange.
I don't believe he said that the Cadillac tax would make health insurance more expensive, that people would go on the exchange. I don't believe he said that.
Employer-provided insurance.
I think he has stated that the Cadillac tax was designed to, because it's backloaded in terms of the way it appears, the way it comes in, that would be less transparent.
Well, it's backloaded so people won't figure it out till years later. He said the American public was too stupid to figure it out. That's exactly
its convoluted design was what he was celebrating because people wouldn't understand how it worked.
It doesn't apply until 2018, and then it's indexed based on inflation, not on inflation in healthcare costs. So, Mr. Antos, moving to you, that would result in employer-provided health insurance becoming more and more expensive, correct?
Absolutely right. In fact,
and it would force people onto the exchanges, correct?
Well, it might force them out of insurance altogether.
So, Mr. Kreisberg, coming back to you, when the health insurance that you collectively bargained for and that you provide to your population, when it becomes so expensive that you can't collectively bargain for it anymore because of the Cadillac tax, and your guys get moved back onto the Obamacare exchanges, are they going to be happy with that?
Well, what would happen is the health plans that they're in would change so they would fit under the cap. We would not necessarily lose our coverage we would still probably have employer-sponsored insurance, but it would be less valuable.
Oh, so I'm sure they'd be happy with that.
They would not be happy with that, which is why we oppose the excise
Antos,
tax.
Over half the American population is covered by employer health provided. A large part's covered by Medicare, a large part's covered by Medicaid. Poor people are covered by Medicaid, retired people covered by Medicare. Most of the rest of the people are covered by employer-provided health insurance, and they really like it, right? Is the Affordable Care Act not an attack on employer-provided health insurance?
Well, former White House official Ezekiel Emanuel argued that the Cadillac tax would pave the way towards eliminating the employer market altogether.
Thank you. I yield back.
Thank you. Mr. Reed, the final question.
Well, thank you, Mr. Chairman, and you are at the end, and I guess this is the penalty for showing up late, and I take responsibility for having the last 5 minutes. First, I just want to make sure this is clear, and I was offended by my colleague on the other side of the aisle who referenced that somehow the Republican agenda is to take away health care for people in America. That's just not accurate, and our committee's better than that, and I will talk to that member personally to make sure that we always raise our discourse, because I think what's here between us on both sides of the aisle is a recognition that the healthcare system is not working in America, and that we have to get to the issue of healthcare cost in particular. And I understand that the heart of this conversation today is about employer-sponsored health care. And it is a big change if we go down the path of removing that exclusion in the tax code. And I am very concerned about that. But I'm willing to put all options before us to have a wide open debate in order to make sure that we're attacking the fundamental problem, and that's health care costs and accessibility for our fellow American citizens. That being said, we are 6 years into this experiment with the Affordable Care Act, Obamacare. So let me ask you a question. Who's been to the doctor in the last 60 days on the panel? Anyone else? How much it cost, Mr. Rowe? How much it cost?
I don't know.
You don't know, right?
Well, because it was covered by insurance, and I don't really get a bill that explains to me how much it costs.
So each of you had indicated that you have insurance through your employer. What'd you pay last month for that insurance?
I don't know.
Mr. Kreisberg, do you know?
The insurance plan that I'm covered in costs, my employer pays for it. Costs probably about $2,500 a month.
How much it costs you?
I don't pay a premium.
You're 100% covered by your employer. And
Yes,
it's
I am.
approximately how much by your employer?
Approximately, I would believe somewhere about
You would
$23
guess,
to $2,500 a month. Yeah, I'm
There
guessing.
you go. You're guessing, right?
Approximation, yes.
Does that not illustrate the point? You are 3 leading experts testifying before the U.S. House of Representatives Ways and Means Committee. Is this not the point?
Absolutely, and it's a question I often ask.
You don't know the answer to that fundamental question. And does that not, in a large part, drive the problem we're facing in America's health care?
I think your conclusion is wrong from the point you're trying to
The lack
make.
of transparency by you as an expert, not knowing the cost, not knowing how much it costs you in the system is not causing the problem, or at least contributing Would you concede that it contributes to the problem?
The problem isn't what consumers know about cost. The problem is what the costs are. The costs, as you're trying to point out, the costs are paid.
Mr. Kreisberg, hold on. I've waited 2.5 hours to have this time.
Yeah.
This is the issue. There are, in my mind, two tools that we can use to control costs. Market pressure driven by people, or government mandate driven by DC. Are there any other tools out there that you can think of? I see a bunch of no's across the table here, right?
Yes.
What we're trying to do is to say to the American people, we stand on the side of you. We stand on the side of a market. Now, you may not agree that it could work in the healthcare industry, and there are going to be situations where a true market does not exist in healthcare. I get that. But our fundamental tool that we're trying to use is market-driven pressure to drive the cost down. Other side, when they celebrate the Affordable Care Act, is saying government is going to drive those costs down. I'm concerned about that, as well as hundreds of millions of people across America that say, if a government can tell you how we're going to drive that cost down in a personal transaction such as healthcare, that is an extensive, big government type of power being exercised over us. So I'm open to trying to empower individuals to have that market-based pressure, giving them their money in an employer-based situation. I have great concerns about it. I will be perfectly honest with you because we have all become accustomed to it. But I do understand the power of what that would represent. And what we're trying to do, is that not what we're trying to do by recognizing the exclusion and saying, if we give that power to the employee, that they may be in a better position to determine and put that market pressure on the system to drive the cost down. Is that what we're trying to get to, Mr. Roy?
I thought you laid it out beautifully.
Well, thank you. As we end on that, I will yield the balance of my time, and thank you to the entire panel for that exchange.
Thank you, Mr. Reed. I'd like to thank our witnesses for appearing for us today. The question is, as we preserve the incentives for employer-sponsored health care, can we update this tax incentive, provide more options in the 21st century world to workers at work or those who want health care outside of work in a way that works for their family and their lives? And we got great testimony and very constructive dialogue today. I appreciate the witnesses. Please be advised, I would like to submit for the record a letter from the Congressional Budget Analysis by Congressional Budget Office that shows that drug price savings aren't obtained by negotiating with Medicare. Please be advised, members have 2 weeks to submit written questions to be answered later in writing. Those questions, your answers will be made part of the formal hearing record. With that, again, thank you for being here. The committee stands adjourned.